And it's now 10 o'clock. If we could begin, please. Just before we start with item 1, we'll be going from items 1 to 4, and then we'll be taking items 10, 11 and 5 next to allow people who are making a presentation to go elsewhere, because as you'll have just heard, Angus IJB has a meeting today as well. So yeah, can we start with item 1? Apologies, please.
Chair, can I just remind everybody that the meeting's being recorded and will be placed on websites, and yep. I'll just do a roll call for the minute as well. Councillor Lynn.
Present.
Bob Benson.
Present.
Councillor Toland. Councillor McHugh.
Present.
David Cheap.
Present.
Colleen Carrollton.
Present. Morning.
I've had apologies from Glyn Lloyd, but I think Alison Penman's here. Yep. Thanks, Alison. Dave Berry.
Present, Arlene.
Christine Jones.
Present.
David Wilson.
Present, Arlene. Thank you.
I've had apologies from Jane Smith and Sanjay Pillai. Raymond Marshall.
Morning, present.
Jim McFarlane.
Morning, present, Arlene.
Christina Cooper.
Present, Arlene.
Nicola Stevens.
Present.
Martin Sloan.
Present.
David Shaw.
Present.
Thanks. That concludes the roll call. So item 1, apologies, have already been noted. Item 2, are there any declarations of interest? I'm not seeing any declarations. So, Chair, I think we're just going to go straight on to item 10 now, which is Tayside Primary Care Foundational Strategy. It's for a decision.
Did we do the minutes?
No, we'll do them after. We'll do them after item 11. We'll do 10 and 11, sorry, 10, 11, 5, and then the minute in the action tracker.
All right then. Yeah.
Okay.
Yeah.
So we're on item 10, Tayside Primary Care Foundational Strategy 26 to 28, and it's for a decision.
Okay, so we have Jill Galloway, who's the Chief Officer of Angus IJB. You've got a busy day today. Thanks for coming along this morning. I'd just like to kick off. Please.
Yeah, no, thank you. Thank you, Chair. We do indeed have a busy day with all 3 IJBs on the same day today. So I think thank you for adjusting the agenda to allow myself to present the 2 papers that I have earlier on in your agenda. So the first paper in relation to the Primary Care Foundational Strategy has been developed in response to just one of the NHS Tayside corporate objectives for 25-26. And really that was around establishing a clear shared strategic direction for primary care across Tayside. The strategy itself has been developed collaboratively with representation from all 3 health and social care partnerships, as well as NHS Tayside, and representations from all 4 independent contractor groups, ensuring that it reflects both the local priorities and the wider system requirements, as well as taking the national direction of travel into account. The strategy itself was endorsed by NHS Tayside Board in April this year. So for members' information, primary care delivers approximately 90% of NHS contacts and is a really fundamental service to support prevention, continuity of care and supporting population health improvement, as well as the longer term sustainability of the wider health and social care system. The strategy in front of you today recognises that primary care is significantly broader than general practice alone and encompasses a full range of primary care services from an independent contractor perspective, including community pharmacy, community optometry, general dental services, as well as general practice, which is what comes to people's minds principally when we talk about primary care. And together, all of their critical interfaces with urgent, planned and community-based care. The strategy itself provides for the first time, a single strategic framework for the whole of primary care across Tayside. As lead partner, Angus Integration Joint Board has the responsibility of coordinating the development of the strategy on behalf of the 3 integration joint boards, as well as NHS Tayside. And this strategic coordination role, and I know I keep reiterating this, but it does extend beyond general practice. However, we have taken a clinically led and professionally led approach across all 4 independent contractor groups. The strategy itself doesn't alter existing operational responsibilities, and it is recognised that operational management and delivery of general practice remains the responsibility of individual health and social care partnerships. So the strategy itself has been intentionally designed as a 2-year foundational strategy rather than a longer-term transformational strategy. It reflects the significant national policy developments that are currently underway, including the anticipated Scottish Government primary and community health route map, which was to be published in June. That has now been delayed until probably August. They have said autumn, so we are hopeful that that will be published then. However, we have had involvement in that, and I can give assurances that the direction of travel included in our Tayside foundational strategy is in line with the national direction of travel. It aligns closely with the National Health and Social Care Reform principles and supports that wider shift towards prevention and proactive care, as well as looking at community-based models of care and reducing health inequalities. And it really recognises that critical role of primary care in supporting that whole system sustainability. So the strategy, hopefully you will agree, provides a practical and realistic bridge between current position and the longer term transformation of primary and community care, focusing in the initial 2 years on stabilisation, sustainability and strengthening the foundations upon which the future can be built on. The strategic priorities that are set out within the strategy are consistent with and support all the ambitions and plans of all 3 integration joint board strategic plans. It focuses on prevention, proactive care, integrated multidisciplinary sustainability, and workforce sustainability and population health improvement, as well as reducing inequalities across Dundee, Angus and Perth and Kinross. So the strategy provides a common strategic framework whilst allowing local delivery plans to be developed and implemented in a way that reflects the local needs of the population. The development of the strategy has been informed, as I've said, through extensive engagement with stakeholders from across NHS Tayside, the 3 partnerships, the independent contractor groups and public partners, in addition to that, with now moving forward into a phase of delivery plan development and implementation. So the report before you has the recommendations that Dundee IJB are asked to consider, but I'll just offer both Dave and David if there is anything in addition that they would want to add at this point, Chair. Thank you.
Dave, yeah.
Yeah, well, thanks, and thanks, Jill, for introducing that today. Really important kind of strategy that we're considering today. And as Jill says, this one has been kind of truly co-produced. We've had involvement as this has progressed as well. So I think the framework itself gives us that kind of good opportunity to meet the challenges that have been set out within the strategy. And I know we've had kind of conversations at this meeting around some of the challenges that kind of primary care faces. So this is a kind of big step in terms of kind of starting to meet those challenges head on. So yeah, I'd just like to thank Angus in particular for their leadership around this and bringing this to us today. Thanks.
David Shaw.
Thanks very much. I just want to echo Dave's comments with regards to both the direction of this strategy. I think it's continuing a route map that was initially perhaps focused on general practice through the 2018 contract, which had a vision of the expert medical generalist helping to support a wider primary care team, and a vision that we've worked within Dundee to try and embed through the additional work and support that we've done with our pharmacy colleagues locally, our other independent contractor groups. I think we've seen huge changes within each contractor stream. We've got growing numbers of independent pharmacists supporting patients in their communities. We've got free-flowing information between our optometry colleagues and our ophthalmologists, and they're increasingly taking on a role in urgent and emergency eye care. I think we have a more resilient system as a result, and I think this foundational strategy brings us towards a future where I think we will have increased resilience, a greater degree of expertise, improved access, and most importantly, improved care for patients.
Yeah, thanks, David. Given your role, I take considerable assurance from your comments. Can I just comment on the actual strategy, I think, rather than the paper? 6.6 dental services. This is obviously a bit different from other aspects of healthcare in that it's not necessarily free at the point of use, but very, very important, not just for oral health, but obviously the impact that poor oral health has on other parts of the body. And I'm pleased to see that we are planning to improve access to both routine and urgent dental services across Tayside. I certainly have noticed a couple of new dentists opening up in my area, at least one of which is will take NHS payments. So just wanted to say that I'm pleased to see that we are looking to improve access to dental services. Dorothy, I think Gillian maybe wanted to comment on that. Yeah.
Yeah, thanks, Chair. And I think just to reiterate that and share some of the learning from the work that has been undertaken across Tayside on a Tayside around general practice. So the sustainability of general practice that has been carried out over a couple of years now in terms of surveys to support how we look at and support sustainability of general practice. We've taken the learning from that and we've created a very similar sustainability survey for general dental services, and we're just in the process of testing that out so that hopefully we will be in a position to look at the sustainability of dental services across Tayside as well. So that's actually a really positive step forward in terms of the provision of dental care across Tayside as well.
It certainly is. I hope we've turned the corner on that. Dorothy McHugh.
Thank you. A comment and then a question. I have to say I found this heavy going, the language throughout the report. However, it's a framework and I take the assurances that we've been given that this strategy aligns with our own. So on that basis, I'm happy to approve it. But there were some areas within the report that I had to read over and over again to try and understand exactly what I was being told. That's my comment. My question relates to, Gillian referred to extensive engagement with stakeholders. What was the extent of engagement with workforce on this strategy?
Yeah, so there was a number of stakeholder engagement sessions held for workforce, Dorothy, throughout the development of the process. In addition to that, we had presented this at all 4 advisory committees for all of the independent contractors. So they have obviously a range of workforce representation at their advisory committees as well. They then took that further into their own domain in terms of dental, optometry, pharmacy and general practice. For that, it was presented at clinical partnership forums where they are in existence, and that has representation from a number of different clinical professions providing care and services within primary care. So hopefully that answers that question. Thanks, Dorothy.
Yes, Gillian, thank you.
Next up is David Cheap.
Yeah, thanks, Chair. Yeah, it was a really interesting report and it was a good one to read. I get what Dorothy was saying. It was a bit difficult in places to get the head around some parts of it. But at the end of it, mine's more of a comment really on the whole thing. At the end of the day, this is a strategy for the whole architecture, if you like, of primary care services moving ahead, and we're centralising it on being a shift away from, you know, the whole reactive to preventive medicine, community-based care, and I think my and I fully agree with it. There's nothing in it I think that I would hold back from. But the question I think as a board we have to address really here is, and the challenge facing us is, the ambition is there, but we've got to make sure that is the ambition achievable, and will it be achievable based on our existing workforce and our continuing financial pressures. And above all else, I think that's what this board has to consider when dealing with all these reports. And the strategy is great and is moving in the right direction, but we've got to consider workforce and the financial responsibilities we have, and just bear that in mind when moving forward with this. That's all I had to say on it. Thanks.
Thanks, David. And next up is Bob Benson.
Thanks very much indeed. I do support the document as a strategy, and I think the question for me kind of relates both to what Dorothy was saying and what David was saying, is about how do we ensure that we are thinking about how we move more staff around out of acute and into community, because that's where the broader primary care is. It's not just about GPs, as Gillian was saying. So there's something about how would we monitor that more in this process, because clearly it's not good for patients to continuously go into hospital for various assessments that don't require intensive processes, but perhaps much more can be done in the community in a variety of settings. And there's also the issue about how do we involve third sector in this as well. So I'm interested just about the long-term thinking round about this, because we all support things like walk-in centres for GPs, for example, but how do we expand or face up that work so that it becomes more of something people would think about first of all, rather than thinking about A&E or a hospital presence. So that's kind of where I'm at.
I noticed, Dave, your hand went up. Was there something you wanted to add at this point?
I'll wait till the other questions come in, because there's a bit of a theme emergent here, so happy to pick
whenever I see an officer, I don't want to put it as out of order, but whenever I see an officer hand go up, I'm thinking maybe you want to comment on something that's been said. But so next up is Siobhan Tolan, please.
Yeah, thank you. Yeah, there is a bit of a theme emerging, because I'm kind of commenting on the same thing. I think it's great that we are making a kind of quite a significant shift into preventative and proactive care, and I think that is massively important. I think it's something that maybe it's something that we've wanted to do for a long time, and this 2-year structure should hopefully kind of come some way in order to do that. I think that this is an element here of kind of short-term investment or short to medium-term investment for long-term benefits in terms of health and in terms of our financial outcomes, because obviously we all know that healthier people, it'll much less strain on the NHS as we move down the line. But my question here is in part kind of connected to the other people's questions. I'm looking through, the report was quite heavy but very, very interesting, so apologies if I might have missed it. There is something about, how we assess whether we've been proactive and preventative enough, and I'm looking at the optometry rate as a good example, but I'm just not quite clear how that data can be dug into a little bit later down the line. There is, and so how do we, in the section at the top, how do we know we've achieved it? It says, we will look at kind of preventable illness, early detection, etc., etc. But how do we begin to unpick that in terms of the data future in 2 years' time? Because it would be good to know how preventative this is, how the strategy is managing preventative care in a very meaningful way. I hope that makes sense.
Yeah, Gillian, would you like to come back on
Yeah,
that?
happy to come in. I think a really important and good question, because the focus absolutely is about prevention, and how we can work differently with all of our contractor services actually. So there will be some, I guess, hard quantitative data that we can look at. So we know that the dental kind of general dental services are keen to look at how they can support kind of long-term conditions and doing some general health observations when people come in for checkups. But just to give a level of assurance, the work that Katie Geary, who's our new Director of Public Health, although I don't think we can get away with saying new anymore because it's a while since she's been in post, that she's heavily involved in this, and the shift in the balance of care corporate objective for this year to support the development of some of those metrics. Siobhan and we take them, are going to be taking them through Population Health Committee. So I think just to give committee assurance that it absolutely is something that we're looking to develop further, and we've got really good support and buy-in from our Director of Public Health to develop what are meaningful indicators, not just from a quantitative perspective, but how we measure real impact on people as well.
Thanks for that response, Gillian. Next up is Martin Sloan.
Thanks, Chair. I'd just like to echo the comments made by David Cheap there about the funding for the strategy. It's a good report, and I do think it's a good example of what we could do. But I do have one downer on this in terms of page 182, in terms of engagement. There was no engagement with, no direct engagement with unpaid carers, and I think that's an area that needs to be rectified for future development of this report and future implementation, because carers not only are looking after themselves, but also looking after 1, 2, or even more people, and getting them involved, getting them at an early stage can help shape it so they can work with more people in a much more collaborative manner.
Yeah, I think Gillian's nodding and taking that on board. And next up, and the last comment I will take is from Dave Berry.
Yeah, well, thanks, Ken, and no, good contributions there, and kind of feedback around the report. So just picking up on that theme that David kind of started with, and is kind of going across it through the contributions today. I think, no, absolutely accepting that. You know, we are working in a system that is kind of really pressurised resource wise. I think for me the framework itself sets out a kind of different way of working, and given everybody signed up to that from the engagement and the approval sort of processes that Jill's described in terms of the route to here, there is a kind of whole system kind of backup for this one. So for me, yes, the resource will always be there, and the challenges will always be there, but this is about shifting our focus. It's about shifting that to that early intervention, prevention, and looking at kind of where we can around, looking at reprioritising different roles. There's no, if you to look at the landscape from primary care 10 years ago to now, it's very much a different landscape as well. We do need to kind of look at digital and how digital can enhance the offer. And that includes, the sort of self-help side and kind of public's own ability to access kind of their own advice when it's safe to do so. So it is that kind of utilisation of that wider system, that whole system approach that will kind of take us to be able to deliver on the kind of key elements within the strategy. Thanks.
Thanks for that, Dave. So it seems to me that we are fairly happy with this report, with some nervousness expressed. Are we happy to approve the report?
Yeah.
Yep, thank you.
Okay, so that then takes us on to item 11. Out of our model of care option appraisal, it's for a decision.
And back to you again, Gillian.
Thank you, Chair. Sorry, we had to transport into a new room, which is why there's been a bit of movement. And Jane,
I didn't even notice.
Our Chief Finance Officer has also joined us for this report. So thank you again. So this report represents quite an important and significant milestone in the reform of GP out of hours service across Tayside, and provides Dundee IJB with assurance that the programme is progressing as planned, following the approval of the Tayside GP out of hours strategic framework at all 3 IJBs back in December 25. Members will be aware that Dundee Health and Social Care Partnership have been actively involved throughout the development of this work, alongside colleagues from Angus and Perth and Kinross, NHS Tayside and our other partner organisations that have a critical role in terms of out of hours care, NHS 24, Scottish Ambulance Service. We've also had public partners involved in this work as well. Since the approval of the framework, a programme of work has been undertaken that has looked at the workforce and financial modelling, tests of change and a structured options appraisal involving clinical, operational, partner and public representatives across Tayside. Hopefully members will agree that the report demonstrates a robust, transparent and evidence-based process has been followed to identify a preferred future model of care which seeks to balance quality and safety, equity of access and workforce sustainability, affordability, as well as operational resilience across the system. I think just to note that this isn't the end of the journey, but is a milestone within the wider programme of urgent and unscheduled care transformation, shifting the balance of care, which we've alluded to before, and how we can support that service optimisation. So the key ask of the board today is to take assurance from the progress made to date, note the options appraisal process, which is in your paper, and be satisfied that a reasonable level of assurance can be provided that the reform programme remains on track and is progressing through the appropriate governance arrangements. I'm just going to bring in Jane, our Chief Finance Officer, just to go through some of the detail in relation to the modelling and the finance element. Chair.
Hi, so I'm just going to bring it round a little bit. Hi, I'm pleased to meet you all. So as part of the option appraisal process, all shortlisted options were individually costed, with the spend profile for the preferred option reflected in this paper, and the additional cost associated with the new model has been captured within Angus Health Social Care Partnership Strategic Financial Plan, which remains subject to approval by the IJB this afternoon. So it's a little bit of a timing with us all around these papers, and that's one of the reasons why this paper focuses around purely the spend profile and doesn't go into any detail around the additional costs associated with that. We had previously captured in a number of earlier strategic financial plans, in particular our draft one that went up in February to IJB, the additional costs that would be associated with this, and our proposal for us to look at how we would then fund that moving forward on a recurring basis. Further to that, we also recognise there will be a transitional period whilst we move from the current to the new model, and through our reserves we are proposing that we would support the bridging, so one-off type funding to cover that over the journey for us to move that, which could be about 2 to 3 years. I would also further add, in regard to the additional cost, what we have seen is since 2020 a 15% increase in activity, and that I think would have been included in some of the information attached in the paper. At the same time, we've also seen significant increases around pay inflation. So a combination of that is what has impacted around our additional cost. And I think that's about everything I would want to say at this stage.
Thanks, and I'll just again pass over to Dave and David just to add to their input to this paper. Thanks, Chair.
Yeah, I'll just come in. So no, kind of just echo what said last time round. We've been fully engaged in this process, fully involved in this process as well from a Dundee perspective. So, it's not there's nothing in this from our side that's a surprise. And given the challenges that Jill and Jane have set out around out of hours services and that increase in demand, and full agreement that this is the best option to take forward. So that's what David.
Again, just to reiterate that there's been extremely close consultation, both with those working within the out of hours and also with patients. We've had a huge amount of engagement. I think the public are very interested in what happens in their care when their GP surgery is closed. We've also recently had the Health and Care Experience Survey that's looked at NHS Tayside's out of hours and compared it with the rest of Scotland, and that's both shown an improving trajectory. We've noted a significant increase in the positivity of responses over the last few years, and also shows that we're at the leading edge in terms of performance from a patient perspective in the various different metrics of how they value their care. I think we have an out-of-hour service that works well currently, but we think we can make one that's better, that's more resilient, that's more patient-centered and is more embedded within local communities. And I think the additional work that we're doing through the weekend work in Angus will mean that more people can be seen close to where they live. The work that we're doing on the skill mix that we have within our profession gives opportunities to develop our nursing professionalism, and that should improve the flexibility of the service as we move further forward. So very much welcome the work that's been put into this, and I think this does set out a good direction of travel for our future out of hours.
Yeah, I think you're still on mute.
Thanks, David. I think just in terms of one additional bit to add is the criticality, and I know we covered that in December when I brought the strategy, but the criticality of a good, resilient, robust out-of-hours service, both in terms of daytime general practice, but also that whole system impact as well, and supporting it is a key service within that whole system across Tayside. Thanks, Chair.
It's me that's muted. I beg your pardon, Dave. I thought you were saying that David was muted. Yeah, David.
Yeah, thanks again, and thanks, Jill and Jane. Welcome as well. I've got a question and then I suppose a comment really on this one. It was useful also having the summary paper at the outset here to quite simple, showing what's really planned here in the option that's being put forward. Being a bit localized, so David Shaw referred to opportunities for local communities to get more benefit locally from this. But Jill, I've obviously dropped the ball with this over the years. Why is Dundee and Perth got through the night services and through the whole weekend services, and yet Angus only ever had a very, very part-time weekend service? How did Angus lose out from that? That's my first question.
Yep, and David Shaw will probably want to come in as well. We've both been involved with out of hours for a number of years now, and I think when you look at the data, David, when you look at some of the changes and developments from a minor injury and illness unit perspective, and it was post-COVID, and David will come in, and when we looked at the data, there wasn't really the level of demand overnight for Angus. And what we found was a number of individuals from the Angus area were travelling to Dundee anyway, because actually it's easier to get to King's Cross from a number of different parts of Angus. So it is something that we've looked at. We've looked at the overall demand. We've looked at how it's linking with our minor injury and illness service and pathway. And that is what has helped inform this preferred option going forward. So it has been data driven, both in terms of not having an overnight service. We used to have an overnight home visiting service, but David will probably come in and elaborate on that.
Yeah, David Shaw, please.
Thanks. I guess first off, quick history lesson. We used to have full service in Angus. In fact, prior to that, we actually had an additional car based in Pitlochry. The out of hours went through some extremely difficult staffing issues in the years prior to COVID, and I think that combined with the requirements of the pandemic meant that we had to look very closely at how we could safely provide a service, and I guess safety sometimes trumps localism, and we felt that the most resilient service was to concentrate on 2 bases in Dundee and Perth, and as Gillian says, that actually fits in with a substantial portion of the Angus community who perhaps might find it easier to get to Dundee than to a remote Angus base. It's a big county, and the routes for some places are more direct to King's Cross. So I think for safety and efficiency purposes, we closed firstly Pitlochry, and then after that the Angus base. Now, Angus does have an active MIIU, which provides local minor injuries and a degree of minor illness work within the community up until about 8 o'clock in the evening. So it's not that there isn't a place to go, it's just a different architecture of care. We think that we can do better. And we started a route back into Angus a couple of years ago by putting in limited weekend clinics, and that's worked really well, and we think we can do better again. We think that the missing component of the weekday evening and the overnight, there is such limited footfall that it just doesn't wash its face in terms of being able to provide a service there. We did look at that as one of the options, and it was excluded on the basis of cost grounds. So this we can do within the envelope that we've got. To do more than this, I think we'd be asking you to spend less somewhere else so that we could do that.
Okay. Jill, can I come in with my comment really on it as well, if that's okay? I think, fine, thank you for that explanation. It gives a bit of the history, David. Thanks very much indeed. I think there's really a thing with the looking at all the resources that have been pulled into this to get to the cost, and it's good to read that, okay, of the £13.5 million is going to be encapsulated within the health and social care budget, which is good. But I suppose from my point of view, looking forward for all of this, is it's not really a question of whether the £13.5 million is affordable now, but more whether going forward it remains affordable with the, again, constraints and resources that we have to hand, and the I suppose, again, workforce again is a key part of all of that. That'd be my only point on it, is that, again, keeping a keen eye, will it remain affordable within the Health and Social Care Partnership going forward? Thank you.
Thanks, David. Chair, is it okay to come and respond? I know it's a comment, but David, I think that's a really, really important and helpful comment to make, and hopefully similar to the Tayside Foundational Strategy, which is 2 years, what we are seeing, these things, they really work closely with the new corporate objective for shifting the balance of care, because the infrastructure within community health services is going to be really, really critical in terms of our ability to truly and genuinely shift that balance of care. And of course, with that comes with the discussion that would be required around the shift of that resource as well. So I think that it is something that we are truly sighted on. It is something that through the work and the hopeful framework that we will come back around shifting the balance of care, we'll be able to pick up on. And all of these different areas really, really feed into that, as well as the work that Katie's doing from a population health perspective around how we really support that shift left, which isn't a new thing, but it feels really difficult to do. But it is something that we are sighted on, David. Thanks.
Thank you, Jill. Thanks.
Yeah, can I bring in Nicola now, please?
Thanks ever so much for presenting that report, both of you, but I particularly welcome the report update, but the approach and the additional information that you've given with regards to the financials, because on the face of it, when I was reading the report, I couldn't quite get it into my head with regards to the gap. So I think you've explained that today, and that is going to be taken forward to Angus IJB if I'm picking that up correctly. Because yes, it is within the current expenditure, but it's not within the current allocated budget, but that is going to be addressed. So I do take great assurance from that. Thank you very much. I was involved in the options appraisal, and I do have to reiterate, you know, great respect for the number of people who have been involved in this over the length of time. It's been a mammoth job, and it's highly data driven. So just to reiterate what David and David were saying earlier with regards to, you know, service provision over the time, there's been a huge amount of work done with regards to what is needed, what's the service usage, etc., etc. So, you know, the methodology and the fact that it's driven by data and evidence is really good. But I'm really particularly pleased to hear about the financials being clarified. So thanks ever so much.
Did you want to come back in there, Gillian?
Yeah, thanks, Nicola, and thank you for all your involvement, because I know you were really critical in terms of the option appraisal process, and added huge value to that process. I think I mentioned in December when presented the strategy, the involvement of Health Improvement Scotland and the work that work has continued with Health Improvement Scotland, and they continue to hold this piece up as a gold standard and really good piece of work in relation to engagement. Martin, I think you're going to come in and say something similar to what you said in relation to the primary care around the importance of carers. That has been taken into account in terms of the engagement around out of hours. I think on a personal level, do not underestimate the impact and the value that carers bring to all parts of our system. And I think having just had Carers Week, it's been again humbling to see the impact that carers have on how we support and deliver care within the community. So I give a level of assurance that carers have been involved in this process as well. I think Jane's just wanting to add something around the finance, Chair, if that's okay.
Yep.
Thank you, Jill. Nikki, it was just to say some of this has been around the timing. So we, in an ideal world, our strategic financial plan would have been approved before now. It's just unfortunate because of the delays around our budget settlement, and therefore we would have been in a different position of what we would have been able to write in this paper otherwise. So hence why we've actually cannot assume what will happen this afternoon, and that's why we've spoken about the cost spend profile in this particular paper.
Thank you, Gillian. Martin, you're up next.
Thanks, Chair. And Gillian, I want to start by saying thank you for the comments about carers. It's good to know that, but my comment is not on carers for a change. A couple of questions. It's actually a question and a comment. The question is, how does the strategy relate to to A&E or emergency now? And how, because there wasn't much mentioned in the paper about its links between that hours and emergency. And the comment I want to raise is on Appendix B, documents are missing. Can we possibly get them sent out at a future point?
Yeah, it certainly makes reference to reduced attendance, unnecessary attendance, doesn't it?
Yeah, but it's not enough detail there for me, personally.
Mm-hmm.
Yeah,
I thought I'd seen the figure 15% somewhere, but reduction, but I can't find it.
I apologise, I couldn't see it myself.
No worries, Martin, and David might want to come in on it as well. In relation to the appendices, I think Dave's already picked it up, and we'll get them sent out individually. I think in terms of how out of hours supports the system, I think that there absolutely is a correlation in relation to how robust, resilient out of hours service is. and the impact that that has not just on emergency departments, but acute medical and surgical receiving, as well as Scottish Ambulance Service. So in the strategy that was presented in December, Martin, that had a bit more detail around it, and because this is coming just as a kind of progress update, we haven't gone into that level of detail, but I would be happy to pick up a conversation out with if required, and I'm sure David will want to come in from a clinical perspective around that as well.
Yeah, David, please.
Thanks. I guess firstly, from a strategic perspective, out of hours is absolutely embedded within an urgent care ecosystem. So if out of hours doesn't work, then ED doesn't work, SAS doesn't work, AMU doesn't work. And I think we have worked hard to make sure that we're not away in a silo, but that we are right in the middle of everybody's plans. So we speak to each other. We've got an urgent and unscheduled care board, which helps to coordinate. We're in the encouraging position that ED are advocating for this sort of model, and they are absolutely right up the middle of all of this. In terms of the way in which we try and do that on a practical day-to-day, we've got a direct contact between our ED consultants and the out of hours, between ambulance service and the out of hours, and that means that using the clinical system ad astra behind that, we can make sure that the right person gets the right contact quickly. The last thing that you want is that you spend 3 hours waiting in ED, and then you've got to go on phone 111, and then eventually somebody speaks to you and passes you through the out of hours. It's an awful patient journey. If you can get to the right place first time, that's the best thing. So from a strategic perspective, we're trying to do that. From a practical day-to-day operational perspective, we're trying to make sure that we have the right contacts to make sure that we can all quickly speak to each other to make sure that the right thing happens for the patient.
So, yeah, so
Thank you.
That would certainly be good if we could reduce unnecessary attendance, because no one wants to pitch up at 9 Wells or whatever emergency department at 2 o'clock in the morning. That's for sure. I see no other hands, so we are asked to support the preferred GP out of our service model, and also to support progression to detailed implementation planning, as well as noting a number of other parts of the report. Are we happy to do so? I see no dissent. Thank you.
Okay, so we're going to take item 5 now, which is Dundee Integration Joint Board Annual Internal Audit Report 25-26, and you have this for a decision.
Yep, and I believe that Jocelyn Lyle and Christine Jones are going to be speaking to this.
Yeah, if I can just briefly introduce it, and then I'll pass over to Jocelyn. So first of all, please accept my sincere apologies for both members and to Jocelyn and our colleagues in NFDF for the late issuing of this paper. And again, huge thanks to Jocelyn and colleagues as well for who've worked alongside us over the last couple of months to actually compile this and pull everything together and submit the report. This report gives the internal audit annual report and the internal control evaluation to provide assurance around the governance, risk management and internal control framework for the IJB. The draft report has already been reviewed by senior management, and we've got incorporated management actions and responses are noted in it. But I'll pass over to Jocelyn to take us through the paper. Thank you.
Morning, Jocelyn.
Good morning. Thank you, Chair. Thank you, Christine. So, as you're aware, this annual report for 25-26 provides my conclusion on the IJB's internal audit, internal control framework for the financial year. Just by way of background, that conclusion is based on a number of things. Firstly, the IJB's internal audits and prior year audits that have been reported in 25-26. Also, any relevant internal audit work carried out in the partner organisations. The really important piece of work is the 25-26 internal control evaluation, and that's appended to this annual report at page 19 of your supplementary papers. And also, we've considered progress with delivery of previous internal audit and other governance improvement action points. So this report is providing reasonable assurance on the internal control environment during 25-26. As I said, the internal control evaluation report is a very important part of this portfolio of assurance. That was issued on the 19th of May and highlighted quite a few key developments during the year. Just to touch on the improvements in risk management in terms of approval of the framework, development of an updated strategic risk register, and improvements in reporting. We've also referenced the update of the Dundee DH&SCP workforce plan and the robust financial reporting and update and approval of financial documentation. I also just wanted to touch on the fact that there have been a number of IJB development sessions during the year covering a range of absolutely key topics. So just staying with that ICE report, that highlighted potential year-end assurance issues. We had 4 significant and 5 moderate findings, and some items for consideration with a lower risk assessment. Just on the basis that you haven't had a great deal of time to go through the report, I'll just touch on those findings. So in terms of the significant findings, we've referenced the need to report whole system transformation through governance structures. We also had a finding on the robust action that's needed to improve management of adverse events and the importance of effective governance oversight in that area. We have referenced the importance of formally agreed objectives and an appraisal process for key staff, and also the potential impact of current acting arrangements on finance team capacity. So those were the significant findings. The moderate findings were around, first of all, the governance action plan and the number of older actions that are still sitting within that. We think that there's a need to streamline that and refresh the presentation of remaining actions. We also had a finding regarding the importance of quarterly reporting of any whistleblowing concerns to the IJB as required by the integration scheme. Another point on ensuring the currency of the published register of interest so that that's publicly available. And also we've touched on the continued action to improve timescales for investigation and response to complaints, and again, the requirement for robust governance reporting on that area. So just to confirm that we have received really strong management responses to our findings, and having reviewed that, all action is planned within reasonable timescales and realistic timescales, which is also important. I think overall that ICE report reflected a clear trajectory of governance maturity, but notwithstanding that, there are areas still to be embedded. So turning back to the annual report, we provided an update on governance developments since the draft ICE was issued, and that starts on page 11 of your supplementary papers. And that internal audit work at year end identified no findings further to those in the ICE report. So for the purpose of the minute, my conclusion is that based on the internal audit work undertaken during the year, the IJB has adequate and effective governance, risk management and internal control arrangements in place. The Chief Officer has implemented a governance framework in line with required guidance, sufficient to discharge the responsibilities of this role. I can also confirm that the 25-26 internal audit plan has been delivered in line with global internal audit standards and the application note global internal audit standards in the UK public sector. In addition, we have not advised management of any concerns around the following. Firstly, consistency of the governance statement with information we are aware of from our work, the description of the processes adopted in reviewing the effectiveness of the system of internal control and how these are reflected, the format and content of the governance statement in relation to relevant guidance, and lastly, the disclosure of all relevant issues. Excuse me, my throat's going a bit. That's all I wanted to highlight, but I'd just really like to take the opportunity to thank Dave, Christine and the wider team for all the engagement and support provided both at year end and throughout the year. And I'd also like to thank Barry and the internal audit team for all their work. So as I say, that's all I wanted to highlight, but happy to take any questions. Thank you.
Thanks very much for talking us through that, Jocelyn. Are there any questions? Colleen, yeah. Quite a few hands have gone up actually, but you're first, Colleen.
Got in there first. Thank you very much for the report and for the summary there, because it's really helpful. Obviously, none of us, I think, have had the time to go through this in as much detail as we would like to. So in saying that, there's just a couple of things that I've not managed to fully go into, but I'd just ask a couple of questions. So seeing that there's, what, 9 audit findings, is that correct? Can I suggest or propose that we see progress of this at potentially every IJB meeting, because there is 4 significant findings, I believe, and I would just like to keep track of the progress for that, for assurance, rather than us getting to the dates that are listed here and finding out that actually we're behind time and it's not happening. Number 9, just picking that one out purely because it really stood out to me. So in the agreed management actions here that we're going to complete by December, I don't see anything different than what we're doing really already, and correct me if I'm wrong, I'm maybe missing it because I've just skimmed it, like I say. But to me, if you've got a significant audit finding and the agreed management action is just to have some more meetings, I don't understand why the agreed management action here isn't to have a permanent Chief Finance Officer. I think considering our financial difficulties and challenges at the moment, that would really be imperative in my thinking. But just if I could have some more detail behind why that's not the case and why it's not implicitly stated. Thank you.
Thanks, Colleen. I think probably Christine or Dave would be the appropriate people to respond on both of those questions, actually. Yeah.
So, Christine, would you like to come in followed by Dave?
Yeah, sure. The actions will actually go into the governance action plan, and that gets reported to PAC every meeting already. So we'll be progressing and noting the progress towards delivering these through that process, and then obviously through the PAC's chair assurance report back to IJB if there is any sort of points of note around that one. And I'm sure Dave will come in on the appointment of sort of the formalisation of sort of senior management, including the Chief Finance Officer. But yes, that is definitely progressing. It's taking longer than we'd ideally like it to go through from a personal point of view as well as from an organisational point of view. But I'm sure Dave may want to come back in and comment further on that one.
Yeah, Dave.
Yeah, no, thanks. That's a fair question to ask around that in terms of why we're not in this position. I'm going to echo Christine's point. We should have kind of been in a position that was concluded before this. What I'm doing, I'm working with the 2 chief executives around our kind of overall senior management structure, of which the Chief Finance Officer is a key role within that, to make sure that we're taking into account all the sort of wider changes and all the wider reform that's going on within that whole system, to make sure we've got a structure that's kind of fit for purpose for the future. So again, I know it's just another meeting, but yesterday I had a meeting, a formal meeting with the 2 chief execs, and we discussed that again, and I've got some actions to take away from that as well. So yeah, accept and acknowledge the fact that this is not an ideal position to be in, but we are giving you the commitment that that's been actively worked on.
It does seem that these talks about the senior management structure are taking some time. When did they commence, Dave?
So I've been in post formally permanently for just over a year. So shortly after that, we started having the initial discussions around that.
It does seem an inordinate length of time.
It does. Thank you, Dave and Christine, for that. Can I just say, and I understand what you're saying, that there's meetings going on around this. I just can't see a possibility that through management restructure that we're not going to need a Chief Finance Officer. So I don't understand why that role's included in that kind of discussion when it should be.
That was my thoughts entirely, Colleen. Yeah. David Cheap.
Yeah, thanks, Chair. And well done, Colleen, for getting a chance to even analyse that. I hear what you're saying, Christine, that unfortunately the report only came in our inbox yesterday, but I had other things on last night that I couldn't get a chance to read this. bearing in mind the poorer outcome financial performance of the IJB for 25-26, poorer than expected. Is there any rush for us to actually, because I see this as just noting the contents, but then instructs the acting CFO to progress towards recommendations. But is there any rush for us to approve this today? Because a 60-page paper like this, which is an annual report, and albeit an internal audit report, it could be deferred this to the next meeting, because I haven't had a chance to look at it. And I hear what Jocelyn's saying and what Christine's saying, but is there any rush for it to be presented to us today when we only had one day to look, or less than a day to look at it?
I think that's a very fair point, David. Who would like to respond as to whether or not we could defer this to the next meeting? Is that possible, or is there some reason why we couldn't, Dave?
Thanks for that, and so maybe can I just check with Jocelyn around that in terms of what that means for the sort of wider assurances, and I suppose the other aspect for me is the impact on our annual governance statement as well, which we would want to sign off from the accounts. But Jocelyn, I don't know if you've got any views on deferring it till it would be the August meeting we would defer it to.
Yeah, thanks, Dave. I think that would be absolutely appropriate to give you the opportunity to read it properly and to apply sufficient scrutiny and challenge. From my perspective, you have my opinion, which is our fieldwork's concluded, and you have the opinion there. So I don't see any issue with deferring it to August. It's been available in time to to be taken into consideration for the draft governance statement. So I think that's absolutely appropriate. Thank you.
Yeah, I do too, and that's what we're going to do. Bob, I don't know if you had much to say, but I'm going to defer this to the next meeting.
Yeah, yes, thank you for that, Ken. I think there's quite a lot in the significant events that we need to follow up in any case at the next meeting, and I think also I take fully the points around the chief finance officer, which is a statutory appointment, which is really important. But also I am concerned a lot about the lack of objectives in the appraisal for the two senior posts here. I find that really strange in any case. So I really have concerns, and stuff that I raised, I think, when we signed off the budget, is around capacity, and I can see some of that wavering in items 7 and 8. That's beginning to impact on some of the stuff that's appearing in reports. So I'm glad that you're going to defer this, but these matters are not going to go away. Thank you.
Thank you. So we agreed to, I don't see any dissent to that, and Martin's put in the chat that he agrees, so we'll defer this until our August meeting to allow members time to properly scrutinise the document. Thank you.
Okay, so we'll go back on the agenda now to item 3A, which is the minute of the meeting held on the 15th of April, and it's submitted for approval.
Are we happy to accept that as a true record of the meeting, or did anyone have any comments regarding accuracy or otherwise? I don't see any hands, so yep, happy to. I think we're happy to accept those minutes. Thanks.
Thank you. Item 3B is the action tracker, which is submitted for noting.
Yeah, any comments on the action tracker? We're now racing through the agenda. Oh no, there's a hand. Colleen.
Not quite yet. Hold your horses.
That's okay.
Yeah, just action number 5 around the timing of the budget consultation. So I asked at the last meeting if we could have an actual date to stick to for that, so that we're not, the previous 2 years we've been kind of racing towards the end of the year. So with the caveat that it might have to be moved nearer the time for whatever reason, but I would really like to see a definite date there, whether it's going to be early February or just something like that we can try and stick to, so that we're on the ball this year with that.
Yeah, yeah, good point. So it's marked as it's complete, but can we do what Colleen's asking? Is that? Yep, Dave's nodding his head. Thank you. Well, that completes the action tracker.
Okay, thanks, Chair. That then takes us on to item 4, Performance and Audit Committee Chair's Assurance Report, and you've got this for information.
Thank you, Bob. Is there anything you would like to add to the text in the minutes of the meeting? Sorry, not the minutes of the meeting. Your report. Dave, Bob, you're on mute.
I'm very pleased with the report that we've done, and I think particularly our oversight of risk management has been pretty clear, and that's stated also in other places. So I'm absolutely delighted with that. I think the work of the committee is robust and it adds greatly to our good governance.
Thank you, Bob. So that's for noting, or for information and record purposes at any rate. I don't think there's any difference. Next item, please.
Okay, so item 5 we've already covered. Item 6, unaudited annual accounts for 25-26, and this is for a decision.
Okay, so we're to you again, Christine.
Yeah, thank you. So thank you. I've pleased to present the unaudited annual accounts for 25-26 for the financial year, ended at 31st of March. Appreciate that we've still got quite a lot of items on the agenda for discussion, so I'll try to keep this relatively brief, but obviously there's some important documentation in this report and in the next couple of reports as well. So the financial statements are obviously prepared and documented under statutory accounting standards, and therefore the presentation of the numbers in the report and the financial statements differs a little bit from the normal financial monitoring reports that members are used to, which is why the next item, the financial monitoring report, is also one for comparison to through the in-year reporting. The annual accounts document itself includes the management commentary, so that's the annual accounts document is included in Appendix D for the report, includes the management commentary in section 3, including a selection of key stats, achievements and challenges through 25-26, and also includes the statutory statement of responsibilities, remuneration report, the annual governance statement, along with this statutory financial statements sections and an appropriate notes. Within the financial statements, the comprehensive income and expenditure statement demonstrates that the IJB has had access to and utilised £382 million worth of resources and funding through 25-26 to provide the adult health and social care services to the citizens of Dundee across the range of delegated services that are the responsibility of the Dundee IJB. The annual governance statement, which we already alluded to through the internal audit report, is also included in Appendix 2 of this report, and also embedded within the actual annual accounts document itself, and the IJB are asked to review and approve this. The annual accounts does confirm a year-end overspend, which we were relied on use of both reserves plus additional funding from NHS Tayside and Dundee City Council under the risk share agreement arrangement as part of the scheme of integration to manage this deficit. And members are also just asked to note that within our reserves, we actually received an additional £1.7 million of allocation funding via an NHS Tayside from Scottish Government late in 25-26. This is to support committed expenditure going into 26-27 under the wider operational improvement plan. And this has been moved into an earmarked reserve and to carry forward to manage that spend in 26-27. So members are asked to note the content of the report and the appendices and approve these for both publication onto the IJB's website and also passing on to Audit Scotland, our external auditors, to commence the external audit process. But obviously I'm happy to pick up any questions that the members may have.
Any questions on this item? Don't see any hand. Yes, Colleen.
Just a really quick comment, seeing the figures there from the delayed discharge work, and really just to applaud the work that's going on there. I mean, our figures are sitting at nearly a quarter of what the Scottish average is. It's really incredible work that's going on. Also, it was a really interesting report, the part about DDARs. We've got a great rate from referral to treatment time, but I was thinking about some of the work we're doing in population health at the moment, which will hopefully kind of feed into this, in that we're trying to look at different metrics. Jill kind of picked up on it earlier, where hopefully we can relate it to this, to picking up kind of the who's still on the programme at like 1 month, 3 months, 6 months, and understand where we might be failing there, why we're not getting the outcomes at the end, and finding the part of the system that's failing. So hopefully by the time, you know, another year or two, we might see some more meaningful data coming out of that, that can impact the population.
Yeah, that's it. There's obviously an awful lot of reports that will come out around performance and activity, and we've obviously got our annual performance report that will be published shortly as well in the next month or so. So the annual accounts will pull out some key information, but we don't want to obviously be duplicating everything that's going into the annual performance report as well. And then there's that sort of public health report, annual reports as well. We'll also be pulling out a sort of comparable but different focus of information as well. Sorry, I've just got one other thing I just wanted to highlight as well. Nicola, please accept my apologies for misspelling your name. We will get that fixed before we pass over to the auditor and that as well. So sorry for that one.
Bob.
Thanks very much, Chair. It's actually a good report. It's an interesting report as well. There are some things when I was looking at the national indicators, that's on page 34, there seemed to be a stubbornness around over the years in emergency admission rates to hospital per 1,000 people over 18. And we seem to be still significantly higher than the rest of Scotland. And it's also similar with falls rate, again, significantly higher. And we've been able to do good things around bed day rates and readmissions. So what's the problem? That's what I'm trying to get at. Why are they so intractable?
I think some of these things are things that we actually pick up on regularly through PAC conversations as well, particularly around some of the falls and the clinical pathway around some of the falls and the admissions of that one. And I don't know if Matthew or anybody else is on the call that can pick up some of that. And that's some of that may be more analysis as part of the sort of quarterly reports that we bring to PAC. Matthew, can you?
Yeah, I'm happy to. What we do know about the falls is that when we're providing care, we know that the care that we provide is having a really positive impact on people that receive that care. We've got really great data around validated outcome measures. So when people come through and see the services, we know that they get a really good quality of service. We've done a lot of work looking at people that have fallen more than twice. And we know that we're wrapping care around them well. And there are reasons why people fall that you simply can't control and take away entirely. So we support people through that process. The rate remains a challenge for us. We're engaging at the moment with the Public Health Department to do some work looking at the patient journey into and through the emergency department. We know that a lot of people will go to 9 miles when they live in Dundee because of the proximity of the hospital. We also know that there's an observation unit within 9 miles, and if people move into there, it classes as an admission. We know that the care that's provided in there is high-level care, and it means that we can return people to their homes having received that care. But we're doing work with population health to explore that journey a little bit better, to understand the journey into ED and to see if our frailty at home services, which are fairly new in terms of actually Dundee, Angus and Perth, and if there's an opportunity for the Scottish Ambulance Service to go through a different route and a different pathway so that people don't go to ED and they come for community care, community assessment and wraparound care to keep them at home. When people do go to ED, we know that a significant number, 53%, stay for a very short period of time, and something like 80% of them have no procedure undertaken. So we feel that this might be a mark of enhanced levels of care rather than that being a problem per se. But the work that we need to do to confirm that is taking some time. I've spoken about this before, but Population Health are writing a proposal to get medical students to work through some of that so they can actually look at the decision-making process that's there.
Thanks very much. I look forward to seeing improvements in these areas. Thanks.
Catherine, would you like to come in, please?
Thanks, Ken. Just in relation to readmissions aspect, thanks, Matthew, for covering the falls side of things. We have done a lot of analytical work historically on readmissions as well, so we do have a good idea about the causes and some of the driving factors or potential driving factors. Part of that, some members will recall, is around recording practices and how they vary between NHS Tayside and other boards in Scotland. And we do know that when we control for that difference in recording practice, the Dundee readmission figure looks much closer to the national average figure, the Scottish figure. But we know some other factors that are driving differences that don't relate only to recording practices are about short admissions. We've been looking at the connection between the original admission and the readmission because they're not necessarily for the same issue. And understanding that, and some of that's driven by our demographics in terms of us admitting people for short periods of time because of their wider vulnerabilities or health and social care needs as well. So I'm happy to share more detail with people of table, but that is something that we've looked at in significant detail, supported by Public Health Scotland as well.
Thank you, Catherine. Dorothy.
Just a quick comment in relation to falls. I agree with Matthew's interpretation of these numbers as likely an enhanced level of care in this area. I had a fall some months ago, but the ambulance staff took me to Nine Wells because of what they called my demographic. So I was well looked after. I didn't need any treatment, but I think the fact that I was taken to Nine Wells was just to make sure that everything that was done that was needed to be done for me.
Glad to hear that, Dorothy. Thanks for that input. David Cheap.
Yeah, thanks, Chair. I mean, the comments here have been primarily on service and impacts, and I know there are papers to come on the financial side, but as these are the unaudited final accounts, we have to, I think, wrap up, summarise this by saying that there's a significant overspend again this year, more significant than we expected even at our last meeting as well, and that has obviously an impact on both NHS Tayside and Dundee City Council for their risk share of all of this, which has had an impact accordingly on this year's budget, as we now know, for the IJB. But I think while there's no immediate financial crisis in the IJB, going forward for future years, and particularly the year we're in now, and 27-28, the margin for error on budgets is narrowing incredibly. We've set a budget that we said said and agreed would be achievable based on mitigating actions and savings. We said that a lot of that last year, and even with the planned savings, we didn't achieve them all, anything like them all, but we got some. But even with all of that, we still had such a significant overspend. So just to wrap up, the main strategic challenge for the IJB going forward is not about governance and compliance to governance. It's about long-term financial sustainability. That's the thing that should be underwriting everything we're doing. And I'll leave it at that because I know there's more to come with the financial monitoring position paper and also the budget paper. Thank you.
Thanks for that, David. I think there's probably quite a few of us agree with what you've just said. But can we agree the recommendations from 2.1 to 2.5, particularly to approve the statement as outlined in Appendix 2, and at 2.5 to instruct the Chief Finance Officer to submit the unaudited accounts to the IJB's external auditors by the 30th of June to enable the audit process to commence? Can we agree that? Thank you. I think at this point, given the need to keep hydrated in warm weather, we'll take a 10-minute break. I've had a look at the agenda. I think we'll still be finished by 1, even with a 10-minute break. So I'll see you all back at 11:30. Thank you. That's 11:30. So can we begin again with the next item, please?
Thanks, Chair. So we're now on item 7, financial monitoring position as at March 26. This is for a decision.
Christine, would you like to speak to this, please?
Yeah, thank you. So yeah, just following on from the previous report of the annual accounts, this report is providing the IJB with the detail consistent with all the in-year financial monitoring reports that we previously provide, looking at the operational financial position and in that same kind of format that you're more used to. So the members will obviously note, and I've already alluded to, the deterioration in the operational overspend at the end of the year, particularly from our previous monitoring position, which was based on the February information, and the full year overspend, operational overspend, moved to £5.6 million at the end of the year. Consistent with sort of previous reports that we share, sections 4.3 and 4.4 detail and provide summary information around the key variances, movements, and the reasons for these changes within the operational service, or the reasons for the overspend or underspend within the operational services. Some of the comments from the sort of previous meeting was looking at some of the swings, and sections 4.3.3 and 4.3.4 are provided some additional information around some of those recent movements in terms of the forecast variance and that year-end closing position that we moved to. Again, as already been alluded to, that it is a year-end deterioration. And because of that, and under our financial recovery plans that had previously been put in place, we undertook a further review of earmarked and ring-fenced reserves before we were in the position to close the accounts and close the year-end position. And that's resulted in utilisation of a further £500,000 of uncommitted transformation funding that was held in reserves towards managing that unplanned year-end deficit, prior to the risk share arrangements being kicking in with NHS Tayside and Dundee City Council. The resultant deficit at the year end, unfunded deficit, was just over £4 million. So therefore that's been funded from NHS Tayside and Dundee City Council with additional investment from them under the risk share arrangements. Absolutely hearing members' concerns and around the late deterioration in the financial position and that year-end overspend. And as sort of professional accountant and financial advisor to the IJB, I share these frustrations, and we're again the sort of lessons learned from the overspend, the position that we've seen, and some of that movement. We're working with colleagues across the organisation to understand the information flow and enhance our processes and get that information into the position so we can take action should something similar arise going into the new financial year. As always, the appendices in the report provide the detail around the financial outturn and additional information to support the content of the report around sort of other sort of key drivers and stats around it. So again, I'm sure there's some comments and feedback and questions from members, so happy to pick up on those.
Okay, as Christine said, I think all of us are concerned about the financial position. David.
Yeah, I'm not going to restate, Chair, things I already mentioned, but I think really the important thing for me is the deterioration, as Christine's referred to, from February when we looked at this and the end of the year. And the bit that concerns me really here is the extent of that, how much it worsened. And, you know, certainly in the papers it does give various reasons, the pluses, minuses, etc., and for overspends, underspends, but it still comes down to one big figure in the end. My concern really from, I suppose, governance point of view is forecasting accuracy is key here, and the fact again that the late deterioration in the actual final result, was there any hidden things, hidden pressures there or whatever? And I hate saying this, but I mean, when you've got something like that, such a large deterioration at such a short time, where's the financial control on that? So that's a kind of summary. I don't want to go into great depth. Other people perhaps have questions on individual parts of it all. I think that I'm just trying to summarise really the cause and effect of all of this, and the fact that it was so substantially poorer than we expected from a forecast that was at the 28th of February. I think I'll leave it at that at this point.
Would you like to come back in, Christine?
No, I wouldn't disagree with some of that, and certainly the some of the communication and internally within sort of the budget holders and our financial team, and that information flow will be enhanced, and we'll have certainly there's lessons learned from a financial team monitoring and pulling some of the information in, and ensuring that we get the right information flow to be alleviating that going forward.
So you would hope then that those lessons learned will lead to more improved forecasting for next year?
Yeah, some of the assurance around it. It's a situation that actually has been an accumulation of a number of different things, but unfortunately it's added up to a very big number this year. That's not a comfortable position from that perspective, but we've got an understanding around it and the key drivers.
Thank you. Dave, would you like to comment, Dave Berry?
Yeah, no, thanks. And so I'm absolutely going to take the points that have been raised, because it is a huge concern around that shift. Not going to try and kind of move away from that. And I know that will kind of give a bit of a kind of shaking of confidence from IJB members of our forecasting and kind of whether how accurate it is, and what kind of what we can kind of trust in terms of that going forward. So we have kind of take, as Christian says, we've kind of taken that, had a look at where these issues were not, where these issues were coming from, in terms of what we would call some surprises from a finance perspective around that, to kind of make sure that we've got enhanced controls in place around that. So obviously, there's, as David had kind of referred to previously, we've got kind of range of financial papers on today, all kind of showing some really significant challenges for us as an IJB. So we need to kind of instill that confidence back in yourselves around making sure that we're on it and we've got the sort of grip and control that you require, and for us to be able to deliver a balanced budget on that. So I'll accept all the kind of comments that are made on this. Thanks.
Thanks, Dave. I'll bring in Dorothy next.
Thanks, Ken. I would echo David's comments about this late deterioration, and I hope that we're able, as a board, to explore this and understand it a bit better through our development sessions, particularly our budget development sessions, which I found extremely helpful over the last period. I'd like to draw attention to section 4.3.2, the second last paragraph, which talks about psychiatry of old age, operational leads collaborating with neighbouring health and social care partnerships to assess local and regional demand for psychiatry of old age beds. Does this have any bearing on the recent proposal that we read in the press around the closure of Kingsway Care Centre? And if so, even if it's not so, I'd like to know when the IJB will be discussing this proposal.
Yeah, it's still unclear what input I think we're going to have on this. I know that they're consulting. Dave, can you comment on that, please?
Yeah, no, I can provide. So there is an options appraisal that's still underway that NHS side is undertaken. So that will come to a conclusion quite soon. and any implications of that will be reported back. However, that is given, it will be around the estate and how the NHS Tayside utilises its estate. That is not something that's a delegated matter for the IJB to decide on.
Okay, Dave. Do you want to come back on that, Dorothy?
Just to say, it is a commissioned service. I'm sure the IJB would have some input on the standard or the quality or the geographical siting of a commissioned service. No?
I think we certainly would have something to say on that, Dave.
So in terms of the IGB's responsibilities and delegated authority, my understanding is that we can only to issue direction to commission a service, but we can't necessarily specify exactly where that service is provided. So for both our kind of partner bodies, it would be around we would wish to commission X number of beds in the system if you were looking at psychiatry of old age itself. So my understanding is that we do not have a role in directing one of any of our partners to deliver a particular service in a particular geography. Yeah,
it's particularly important given the patient base at Kingsway Care Centre that the services be delivered from a location that's geographically convenient. But what you're saying is that we have no input on that. But
I would really like to explore that in some further depth, whether an IJB or offline.
Yeah, sure. I agree.
And I intend to pursue that. Thank you.
Thank you, Dorothy. Colleen.
Yeah, thank you. I similarly would echo David's comments from earlier, and yeah, I really hope that we do now have some understanding of the key drivers that were behind the inaccuracies with our forecasting, and hopefully don't stumble across the same issues again. I just wanted to pick up a little bit on PDF page 86 around absence rates. I know that this is in the action tracker for having a development session around this, but it just never seems to be coming round, and I understand the pressures at arranging these dates and things, but I mean, they're really stark figures that we've got in here. The 7.35% for NHS staff is not acceptable. And then when we look at health and social care partnership staff from Dundee City Council, 11.2% is huge. So firstly, I would like to know what the actual cost of that is, how much that is costing us in year. And I would more importantly like to know what we're doing about it to support staff in this way, because we're clearly failing somewhere.
I'm not sure how full an answer you can give, Christine, and then Dave, please.
Yeah, the supplementary staffing spend is noted in there, but we don't have necessarily a breakdown around how much of that is due to sickness absence, how much of that is necessarily due to vacancies or the sort of increased demand and the complexity of some of the patient group or service user group that we need to put in enhanced staffing. So there is a highlight around, and the figures are in there around the spend and supplementary staffing, but to correlate that just directly to absence is harder to do, and obviously in some absence will not be covered, particularly some short-term absence we won't be bringing additional staffing, but there probably is an element of productivity gap in terms of sort of a lost sort of productivity, and yes, I mean we have had some sessions previously around absence and well-being and supporting staff both internally within it, but also with IJB members. There is some of the reporting, but we can look at how what we do bring forward and how we further enhance that for the current IJB membership.
So you said it's hard to quantify exactly how much the spend is due to staff sickness, but not impossible. If we could get that, it'd be useful. But I think the key thing here is is to try and get that 11.2% from the council side, both sides, 7.5 sides.
Yes, absolutely.
11.2% is particularly unacceptable.
We have done a number of sort of deep dives through some of the absence to understand some of the absence reasons, and those absences are reasons are varied. I see Angie's hand has gone up as well, but the absence reasons are varied. Some of it, or a lot of it, is actually out with necessarily work-related issues, and therefore, well, we will support the staff. It is not something that we have any sort of direct influence or control around. There's recovery, and also even just recognising that the demographics of the Dundee Health and Social Care Partnership workforce represent effectively the demographics of Dundee City wider population. So the sort of frailty, the age profile, the health inequality aspect of it is representative in the workforce as well. So that becomes that added challenge to it. But I noticed that, I think Angie's hand went up. I'm not sure if I've taken her stolen her thunder from.
Yeah, Angie's hand is up. I'll maybe bring Angela and then Dave Berry in after that.
Thanks, Ken. Yeah, there's a few things around this. So firstly, Christine's right, we've done quite a lot of detailed analysis, and unfortunately what we're finding at the moment is that there's a significantly higher than normal rate of things like cancers and some really, really tragic family circumstances, that there is absolutely nothing we can do as a partnership other than support the person to, through these things. Where there is elements that we can support staff to return to work more quickly, there is quite a significant wellbeing support in place, including wellbeing champions. When you're comparing the data for the NHS and the council, they're actually comparable levels, because once you add in the additional sort of carers support, parental leave and things that are within the NHS system, it actually comes out around about the same percentage overall. So you're comparing apples and pears a little bit with that. So it's just a word of caution. The other thing that I wanted to say is the DCC supplementary spend. So that increase that you're seeing in February and March, that is largely attributable to the delays in recruitment, because there was a temporary hold on recruitment for the budget implications. Actually, all it did was push that spend into supplementary spend. So there's a lot of complexities within this to take into account.
Can I just jump in quickly? Thank you for all the responses. If that piece of work's already been done and you've looked at that in great detail, would we be able to have sight of that, just to give us a greater understanding?
It's not collated centrally, so each individual area has been doing it, but we could pull some of that together for you.
Just to give us a bit of assurance.
To just get it collated.
Yeah. Just get a bit of assurance that we are supporting staff in the correct way. I understand what you're saying if there's extenuating circumstances, but for the staff that we can have an impact on, it would be really good to see what the supports are that we have in place and how well we're doing at it, how successful they are. Thank you.
Would the August meeting be too ambitious to collate that information and present it to the committee, Angela? You're on mute, but I think you were nodding your head.
I think that should be okay, Ken, yeah.
Okay, thank you. Well, if we could have that for the next meeting, that would be great. Dave?
Yeah, no, just briefly, because I know there's others want to come in just on that on that issue. So again, just to provide some reassurance that as a management team, we are kind of really focused on improvement around this. We're looking at all the interventions that we possibly can around it, whether it's around kind of making sure that the absence management policies are being adhered to. Try to understand, as Angie's going to set out, what are the reasons why. I mean, the biggest percentage kind of reason for absence is around mental health and well-being. So we know there are kind of real concerns around that, and we've also kind of hosted an extended management team kind of meeting where we focused on health and well-being and what support options are available from both the partner bodies around supporting our employees. So it's the offer from NH&SCP side and also from Dundee City Council. So there's a lot of good work that's been undertaken there. And for me, there's also some connection in with other similar services within the local authority side in particular, because traditionally both social care services and construction services have had, one of the highest absence rates because of the work that's been undertaken. However, the construction services have managed to kind of start to reduce their absence levels. So it's about kind of working with them to understand what did they do, what's the kind of key things that triggered that or changed in their trajectory. So just a bit of a reassurance that we understand this is a massive risk for us, and it's an area that we're really focused on as a management team.
There's been a couple of comments about development session in November. I'm wondering if it'd be better perhaps to take some time over this and bring that information to a development session in November rather than the next meeting, but we can discuss that off table. Maybe give us, if it was a development session, give us more time to go into it. Bob.
Thanks very much, Chair. I noticed that this is the March turnout. This is now June. I don't have much reassurance that things are improving. So there's something fairly urgent about this, Chair, in terms of where we are with financial recovery. And you can see the chickens coming home to roost here from the internal audit report around lack of finance team capacity, no clear objectives for Chief Finance Officer and Chief Officer. So you can see where the issues are now beginning to arise for us here. And I don't really have the confidence at the moment that we can wait. So we're going into the next month, which is the remission period. So we need to get some clear information this by August at the absolute latest. Otherwise, we can't wait till November. That's 2/3 of the way through the financial year. I think that's far too late. And I would
you're talking about the absence levels here, yeah?
No, I'm talking about the financial situation as well as the absence levels. So it just seems we're moving into a kind of critical period. And as I said, when we set the budgets for this year, and I was pretty sceptical that the forecasting was going to be correct, and I think that's going to prove to be correct. So I'm worried about the urgency of how we're going to address some of these overspends, and I don't think we have to meet in August at the absolute latest, I would say. So I think there's something here. Otherwise, IJB can't do anything if it waits till November. It's far too late.
Siobhan.
Yeah, thank you, Chair. I'm just going to pick up on Dorothy's point again, and I'm sorry, Dave, but I'm going to dig a little bit deeper into the Kingsway Care Centre because I'm kind of left slightly more confused than what I was when I started here. So my understanding is that the IJB commissions the service, but of course the place of that service is under discussion, under threat, etc., etc. So my concern here is it picks up what Dorothy was saying. We can commission the service, but what happens if the place where the service is being provided actually impacts on the care? So I'm thinking, this is the only care service that we have for those type of patients in Dundee. So say technically it could be moved to Perth, which is one of the rumours I've heard, that would obviously cause concerns for people within Dundee. So I'm just trying to get a clarity here, in terms of where those boundaries of responsibility lie, but actually the concern that we have no say on where that service might be provided when it becomes a care issue. And I'm in agreement with Dorothy. I must admit, I do think that this requires a wee bit more unpicking and clarification. There is quite a lot of rumours. I mean, my understanding was that staff were told that they were no longer going to have jobs through the unions, etc. So there's a lot of confusion around that issue, and actually a lot of distress around that issue as well. So I really would like clarification on where that is, because I don't think you can separate place from care in such a clean and neat way.
I agree with that, but I'm also not keen to spend any more time on Kingsway Care Centre this morning, which isn't relevant to this paper. I doubt that you have anything to add to what you already said, do you, Dave? No. Jim?
Oh, sorry.
Yeah, just going back to the discussion around the levels of absence, and welcome the clarification from Angie around how we compare the figures, because it is important that the messaging and the language that is used when we discuss this, is really, really important. That first of all, we have to recognise that amongst the workforce as well, morale and everything else like that is low because of the year-on-year kind of budget cuts, but increased kind of demand and pressures on that. And in a lot of sectors, the whole recruitment and retention crisis or certainly issues, and that's not just restricted to Dundee, but nevertheless, it's a contributory factor. And I think when we discuss things like absence, we need to be very, very careful that we're not kind of coming across as condemning the workforce, that this is a kind of employer's situational responsibility to deal with that. The individual kind of management absence and stuff like that, is important in how we support people. But this has been a however many years it is of cut on year, and to expect then the workforce just to absorb have an impact on that, and at the same time not being able to replace colleagues when they retire or leave, as a huge factor. So I welcome any kind of proper discussion and work on analysing that, but I don't want any kind of messaging to go out or for the workforce to pick up thinking, well, here's the IJB having a go, saying, playing at the perception that somehow public sector workers are lazy or more often than other sectors, because the reality is the type of job that you do is very, very different. So when we're comparing, we need to be very, very careful on that. I'm just want to make sure that we're all kind of aware of those type of consequences of that messaging then getting out.
Yeah, absolutely. I agree with you on that, Jim, and we certainly wouldn't want to send a message out that people shouldn't be off sick if they're sick. But I do think it's right and proper that we query these high levels of sickness absence, given the impact that it's having on our finances too. Colleen, yeah.
Sorry, Ken. Sorry to jump the queue. It was just on the back of what Jim's saying, just in case my comments have been misconstrued when I first said it wasn't. I was concerned about the welfare of staff as to why we have such absence rates. If there's something wrong within our system that's causing that it's not a great place to come to work, just basically in the basis of it. So just to clarify that was my concern, not that staff should be pumped back to work when they're not able to. Just.
I don't suppose we have any stats on whether or not we're an outlier in terms of absence levels in the 29 IJBs in Scotland. Is it 29? Yeah, it's close to that anyway. That's the number of councillors in Dundee. That's why I'm saying 29. It's probably 32, is it? Do we have any stats on that? Are we an outlier, Dave? You don't know. We could maybe have that as part of our session then that we've got planned on absence levels. David.
Yeah, sorry, Ken. Totally disagree with what you just said. I've heard this so often, and I've banged the drum so much about it. It doesn't matter where we sit against other IJBs or whatever. The figures are so poor on absence. To get into being double figures for absence rates, no wonder we're in the financial mess we're in. And I'm afraid that if we look into even NHS Tayside, we're sitting at 6.5% in NHS Tayside. Why are we in 11.2% in Dundee City Council staff in the Health and Social Care Partnership? What Jim said, I get what he's saying. We have to have care for our staff. There's no doubt about that whatsoever. But when I keep hearing about this is as a result of cuts and pressure, I would like to see what the figures have been maybe for the last 5 years in that case. And I'll bet the figures aren't terribly dissimilar from what they're showing now. And that shows an underlying issue out with cuts and efficiencies. These figures are not represented in many other facets of work in industry. They're in the public sector, despite what Jim says, they're where the highest ones are. And so I just disagree with that. We need a fundamental change of thinking here in order, when I talk about sustainability, that has to change as well. It's as simple as that. And going back to, to go back to the original point I think Colleen made, it was about before we got to this, or Bob did. You can tell me I'm a bit cross about this, but yeah, here we are almost at the end of June. And when I talk about, and I mentioned earlier on about forecasting and the ability to have accurate forecasting, I would expect today, when we're on the back of such poor figures for the last financial year, to at least have had a forecast as at the end of May. We don't need all the I's dotted, the T's crossed, all the departments to send in all the data. We should have our finger on the pulse that we know we can say to the board at the end, a month after a month end, here's where we are after the first 2 months of the financial year. So this is, all these things are underlying to why we aren't achieving what we're planning to achieve. We need a complete change of thought on our approach and presentation on all of this. So I feel quite strongly about that, the financial side and on the absence side of things. We need a complete change of thought and process in all of this. Otherwise, we'll be seeing these figures again, 26, 27, 27, 28, and we'll be hearing the same old excuses for it. Sorry, that's it.
Yeah, thanks, David. That contrast you made between the absence levels between NHS Tayside and Dundee City Council, which I've also weighed myself this morning, I'd be interested to hear more from Angela during our development session or the next IJB, whichever it may be, about why it's not, we're comparing apples with pears. I didn't quite have enough time to take that in, because I know that Angela's suggesting that the true figure is much closer. But anyway, Raymond.
Yeah, thanks, Ken. A couple of points here. One, I've got to agree with what Jim said, and David. Sickness absence is very complex, so we need to be able to support staff through the policies, because it's not just a blanket approach to that. And I would disagree, David, with your comments. I think, can I just give some reassurances, Ken? I don't want to dwell on the Kingsway Care, right, but can I be very clear? The trade unions have never said to any member of staff within Kingsway Care that their jobs are at risk.
I really don't want to discuss Kingsway Care Centre anymore. It's not relevant to this paper. It's a separate issue.
I appreciate that, Ken, but to make a comment that the trade union said that staff's jobs are at risk, we have never said that to staff within Kingsway Care, because their jobs are not at risk, right? Because as Dave's described, it's the site that's being discussed, not the staff's jobs or the volume of that. So there was just that. So I just wanted to make that point, Ken.
I can see why you want to make that clear. Yeah.
It would also be useful to clarify the point that I said, that it was anecdotal, and I did hear, that's what I heard, not necessarily that it was fact.
Christina.
Thank you, Chair. Considering what everybody else has said, and it's maybe moving forward, that there's a great deal of data and intelligence goes into these reports, and it's maybe the context in the reports that we need to maybe review. When you listen to what Angie and Dave has said there, if the members understood that context, then I think we would have more assurance around the numbers and that data intelligence. And that may be just adding a bit of narrative, like what Angie had presented, and that would help us say, well, this is why it looks at 12% and this is where we're going. I think if we had a bit more balanced approach, it would give that greater assurance, really, because sometimes it's not as significant as it appears.
Thank you, Christina. So that's been quite an invigorating debate around this paper. The recommendations are that we reports for noting, and also at 2.4 that we remit the Chief Officer to review the risk register with reference to the information contained within Section 6. Can we agree that, please? Thank you.
That takes us on to item 8, Dundee Integration Joint Board Budget Update 26-27. It's for a decision.
Okay, thank you. I think it's Christine. Yeah.
Yeah, thank you, and absolutely picking up on the strength of feeling around the financial position and from members today. So again, please accept my apologies for the late issuing of this report. It is a shorter report than the internal audit report, so hopefully members have had a chance to review the 4 or 5 pages of the report. I'd be happy to pick up any questions and conversation after I've gone through a couple of key points of it. So the report is presented to you as an update onto the budget agreement that we set on the 31st of March. At that point, as members will be aware, on an annual basis, the NHS Tayside formal budget setting process is not complete at that stage, and we always come back with a sort of follow-up report in June with confirmation around the NHS Tayside budget settlement. The Tayside Health Board budget was set on the 30th of April, and while we were obviously aware of some of the potential sort of future implications around that for IJBs, obviously the formal setting was after our last sets of meetings. And as a result of the Tayside budget settlement, there are financial implications for the current year for 26-27 and going into 27-28 for Dundee IJB around the resources that we had been previously presuming would be in place for us, and in terms of what was actually set around the budget our own budget settlement and financial plan for 26-27. The deterioration in our own financial position for 25-26, the financial year end, and also the resultant financial implications for NHS Tayside around their year end position did actually have a direct impact onto the resultant year end flexibility for NHS Tayside to provide sort of in-year financial support to Dundee IJB, which would have actually alleviated and addressed the immediate pressures for our own budget settlement. The net impact of that is a £1 million reduction in funding for 26-27 for the current financial year compared to the budget assumptions that we'd actually previously incorporated and approved through the budget report. So in section 4.4, this is highlighted in terms of some additional in-year enhanced and additional management actions, including whole system scrutiny and control measures that have actually been implemented through NHS Tayside themselves and already been implemented through Dundee City Council. So we're looking at sort of enhanced management actions and scrutiny and control to address the additional £1 million gap that we have in terms of this year. And it should also be noted that the treatment and the 3% recurring savings target that's been applied the current financial year, which is noted in 4.3.4, is equivalent to £4.6 million. However, we do have the assurance and the clarification that non-recurring population health settlement adjustment has been implemented and added back in to offset that for the current year. So while we know that that'll be incorporated into 27-28 future budget planning, that part of it is not a direct impact into the current financial year. And just to reiterate as well, the approach from NHS Tayside to sort of budget settlements for the IJBs and also for the retained board services in terms of the pass-through of funding uplift in year and the application of a savings target is actually consistent across Tayside this year. So we're not being treated sort of any differently in terms of that, and it's absolutely reflective of the overall challenging financial position across public sector organisations, and that ongoing wider need for reform and transformation to manage the levels of demand and capacity across the organisation. So members are asked to note the content of it and approve the recommendations, and also instruct the Chief Officer to issue the direction incorporated into the report back to Dundee City Council, NHS Tayside. And apologies, we realised late yesterday after issuing the report that we actually omitted the recommendation about the issuing of the directions. So Arlene, if it's all right with you, then we'll add a 2.4 recommendation into the report just to note that there's directions to be issued.
Yeah.
Again, I'm sure that there are comments and feedback around the conversation.
Yeah, I think we can amend the document as suggested with a 2.4. I think this is the first year really that the indicative NHS contribution, which is always quoted at our budget meeting, hasn't eventuated. I was saying this today recently. It's difficult because we're relying on NHS Tayside and Dundee City Council for our funding. And it would just kind of make sense to me to have our budget meeting after they have theirs. So then it's never indicative. We know what the offer is. But I don't know if that would require legislation, because I think we're required to set our budget by March the 31st. The other thing I wanted to ask, and I would have asked this off table, was at 2.3 in the recommendations, we're asked to approve the proposal to address this through enhanced management actions. I would have thought that was something that management would just go ahead and do, because what are the implications if we refuse to approve that proposal? That's a question for Christine or Dave.
Maybe it should be approved, and maybe it should be acknowledging that will be dealt with through enhanced management actions. But
yeah, I'm sorry for asking this late in the day. It's just I was out all day yesterday, and I would have called you yesterday just to check on that and have it reworded. So if we could have that reworded as well, Dorothy. Oh, I wonder if Dorothy's maybe.
Sorry, I'm having trouble with getting my finger on the right place this morning. Yeah, the timing in relation to 4.3, the timing of budget settings not really working all that well, is it, for us as IJB members? And it concerns me that despite assurances given at our very useful IJB development budget sessions on NHS Tayside's funding, it didn't really pan out as expected, and no one really highlighted this as a risk. You know, at these budget development sessions, nobody said, well, this is definitely what we'll get from NHS Tayside, but nobody, on the other hand, said, you know, what we got was, yeah, that's very likely, that's probably what's, you know, there's nothing to see here, but there was something to see here this time. So that concerns me, and I think the crux of the matter is probably the timing of the two budgets. It just doesn't work.
Yeah, I think we were maybe lulled into a false sense of security in terms of risk, by the fact that the indicative budget has always been what we received. So yeah, unfortunately not this year. Next up is Colleen.
Thank you. I'm a bit confused with the narrative that's here, because I was under the impression that NHS Tayside have passed over this amount of money, but some of it got used to bridge the gap from 25-26, which has then reduced what's available for this budget outlook. Is that not correct?
So the position, we weren't absolutely anticipating that there would be non-recurring funding to close the gap for 26-27 and alleviate offset the reduction, and then due to sort of that deteriorating position, there was no longer that year-end flexibility within NHS Tayside to provide us that funding to offset the implications. So that's kind of, we were always under the expectation and the assurance and the understanding that we would get that non-recurring funding coming through to us, and that's sort of the in-year adjustment for 26-27.
Okay, so it's just kind of mixed together then, that it isn't that the money has been taken from this, it's that the money has had to be used to bridge the gap that was remaining last year that we weren't expecting, that we didn't forecast. Is that correct? that we've had to use some of this money that NHS Tayside had allocated for 26-27 to bridge the gap from last year that our forecasting didn't account for. Is that right?
Dave, you were more involved in some of the conversations.
Dave's hands up too.
Yeah.
Thanks for that. So there's the different aspects here. One is around obviously the budgeted resources, which are less than we had originally anticipated. However, that kind of the expectation around year-end flexibility, which was similar to what we had going from 24-25 into 25-26. And where NHS Tayside would have been in a position to provide additional funding for us at the year end, which we could carry forward into 26-27 to support the position. That was the intention, but it changed because of the shape of, mainly because of our overspend coming into the financial year. So in effect, what you're describing is technically correct, colleague, because it was in effect the money that would have been utilised for our investment in 26-27 was largely used to kind of support the 25-26 risk share contribution from NHS Tayside.
Okay, thank you. Thanks for that. I've only had time to skim this, so I wasn't sure really with reading it how that was, but thanks for that.
So I think, Martin, I'll bring you in next, and Martin will be our last speaker on this item.
Thanks, Chair. Just a very quick question. The 4.6 million savings target that we now got to incorporate into our financial planning, have we got an idea of how that's going to impact on our overall risk on financial sustainability, or do we have an idea or not in that position?
We have already started the sort of the internal financial planning for 27-28, and that sort of future year that's starting much earlier this year. There will be a sort of 5-year financial outlook brought to the IJB in August, which will incorporate the impact of the additional 4.6 million into the next financial year. But obviously it had not been incorporated into previous planning assumptions for that forward look, and obviously this is quite a significant a value that will have a major impact, and therefore the sort of pace and scale of both our savings plans, our transformational delivery, and by that I actually incorporate sort of that whole system transformational delivery. So it's not just the direct delegated services, but it is that wider whole system pathways that will sort of support the whole system changes. So all of that will all need to be brought into play and progressed at sort of even faster and more imperative pace and scale to actually return us to financial sustainability. But absolutely recognising that where we are just now, it remains a sort of really significant risk in terms of how we actually deliver this, but also continue to be in a position to support and maintain the health and social care requirements and demands for the population of the city. But even going back to some of the conversations earlier around continued sort of prioritisation of that early intervention, prevention, population health, individuals accessing information and self-help, self-care, all of that type of thing is that longer term strategy around how we manage the spend and manage the resources to meet the needs of the sort of the people that actually come to the services.
Thank you.
Thank you, Christine. So if we can move to the recommendations, which need to be slightly amended. 2.1 remains the same as does 2.2, but I'm proposing to remove the word approves. So that it just reads, acknowledges the risk associated with the additional funding gap for 2026-27 and the proposal to address this, etc. Are we happy to remove the word approve? I see no dissent. And also to add a direction at 2.4 as previously described. Happy with that? Given that we're happy with the amendments, are we happy to agree all the recommendations? Thank you.
Okay, so that takes us then on to item 9, Tayside Together Palliative Care Matters for All strategy, and it's for a decision. Yeah, so Dave, I believe you're going to speak to this.
Yeah, no, thanks for that, Chair. So yeah, just pleasure introducing the Tayside Palliative Care strategy to the IJB today. Just for background, this was an NHS Tayside corporate objective over 2025-26 to develop a Tayside-wide palliative care strategy. And that's on the back of the publication of a national strategy, Palliative Care Matters for All, which was published in September of last year, and that covers the period 2025 to 2030. So the strategy itself has been co-produced across all of the kind of 3 health and social care partnerships, the acute sector, the voluntary and third sector, kind of hospices, and a care home sector as well, alongside people with experience as well, and also a range of professionals and clinicians that are around the system. So it's been taken forward through a kind of convened Tayside Palliative Care steering group, and also kind of uses the palliative and end-of-life care managed care network as a bit of a sounding board as we progress through this. So there's been quite extensive communication engagement with a range of professionals and also communities around developing the strategy itself. The strategy itself sets out a shared vision for palliative care across Tayside, and it's for people of all ages living with life-shortening conditions, those who are dying and those who are bereaved. It aims to ensure we've got the right care at the right time, the right place, for the right people, the right experience and the right outcome. It will lead to stronger, better connected communities and services, and support being grounded in what matters most to individuals and families. So, you know, there are a number of reasons why we need to have a strategy. Demographic trends, as we kind of see throughout our kind of conversations today, kind of shows we've got a rising population aged 75 plus, growing complexity of people's kind of conditions. So people are living longer with multiple longer term conditions, frailty and dementia, and also, unfortunately, a rising need in children and young people. So we've got around 450 to 500 people living in the Tayside area who have life-limited conditions. And also the inequalities challenge, so that people in the most deprived areas still experience significantly poorer health and lower life expectancy. So the strategy builds on, as said, that the national vision that's been set out. There are 8 priority outcomes that are kind of set within the national strategy, and within the Tayside strategy, these are kind of reflected back into what does that mean from a Tayside perspective. What is it we do, and where is it we need to kind of do more, and what we're doing about it. Excuse me, sets out within the strategies themselves. And it is truly kind of a whole system approach. So while I have the executive lead from an NHS Tayside perspective on specialist palliative care is provided across a whole range of services and kind of scenarios as well. So it's around kind of, so the strategy is that, can say, a whole system approach to how we will deliver palliative care as a whole system over the coming period. In terms of the strategy itself, it's going to all 3 IJBs today. Excuse me, NHS Tayside board tomorrow. Excuse me, and once it's hopefully approved by all partners, there's a public-facing and easy-read version are being developed and will be issued once the strategy has been approved. In addition, there's a delivery plan that's being developed with a timescale for delivery of August 2026. Happy to answer any questions on the report.
Yeah, really interesting document. I'm glad there's going to be an easy read as well. I actually thought quite a lot about what was an easy read anyway, and found that the definitions, you know, about, you know, potential misunderstandings, section 3 of the actual strategy to be really useful. You know, the common misunderstandings. So yeah, if we can get public facing document for that would be great. Let's see, Martin, you're first, please.
Thank you. Just to say that I attended an event a few weeks ago at RBH about palliative care, hosted by the team who's developing this strategy, and I saw an even earlier version of the strategy, and it's been improved somewhat since then. My questions are, I raised them with the team there, but I'm also going to raise them here. One of the issues about palliative care is, in relates to carers, is a lot of carers don't have the knowledge or don't have the information that they need to be able to be effective in supporting their loved one or their neighbours or whoever they're supporting in respect of end of life care. And I would like to see more involvement of carers, because again, I found out that there was very little involvement of carers, and I think that's a major problem, because we are one of the main supporters of people who are at the end of their lives. So I would like to see in future development more involvement of carers, but also I think the report itself is quite good. But again, it's just, I feel there's something wrong with it. I can't put my finger down exactly what, but I think there's something intrinsically that it's just document just doesn't have there, and I think it's something which I will take off our table in future. But I think overall it's an okay, but it needs improvement.
Thank you, Martin. Colleen.
Thank you. Yeah, I'm going to sound like a broken record to Dave, because he's already heard me comment at Population Health and today and then board tomorrow around this. But so similar, interesting in Martin's comments about the carer involvement maybe not being as much as he would hope, because that's, to me, a really vital part of people who are supporting with palliative care would be carers. So reiterating what I've said previously at the Population Health Committee, we had quite a big discussion around this. While we obviously support the review of palliative care and, you know, getting it right for everybody, with the document, I didn't really feel like there was enough detail, understanding that it is a strategic document, and pleased to hear that we've got a timescale now for the delivery plan coming out, because that was something that I would have liked some timescales in this, but eagerly awaiting the delivery plan to see what we're going on. Things like on the 8 outcomes, where we've got a section that's how will we do this, it felt to me more like a what will we do. I didn't really see any definites there as to how we're going to do that, but hopefully that'll also come out in the delivery plan. One of the concerns for me is on page 120 of the PDF, 114 of the pack, that we do not have data for Dundee community, and I don't know why that is when we have it for Perth and Kinross and Angus, and given there's quite a stark difference between Perth and Kinross and Angus, it would be really useful to have Dundee's data, because my concern is there that we're not going to meet the needs of the population when we don't understand who they are and what they need currently. Given that they also have significantly different demographics, our 3 areas, as we all know, are very different demographics wise. And that's probably all I want to say on it just now, but I agree with Martin. I don't know if some of that maybe covers what he felt was kind of missing, that it just didn't feel, I don't know, substantial enough. I'm not sure, but thank you.
Thank you, Colleen. Nicola.
Yeah, it was a good strategy document, as strategy documents go. It was the first time that I'd actually had sight of it, although I was aware of all the kind of development sessions previously for it from the palliative care working group. I mean, there's a huge amount of work actually going into it, but there's a massive amount of work to realise those aspirations. As a service user and as an unpaid carer for somebody who is elderly, I can't actually think of needing one of the right care, right time, right place, right people, the right experience and the right outcome. Now that's from a general palliative care, kind of the earlier stage of things. I'm not talking about the specialist palliative care. And that's really, really sad. A lot of it is about not fitting up things. A lot of it's pretty basic. There's a lot of things that I potentially couldn't answer. There's a lot of things to do with communication. And then there's a lot of things that going through the end of life, I'm not meaning dying, but those latter years, it's difficult. And there's some things that, you know, we'll probably have to accept that, you know, are just going to happen anyway. However, yeah, there's an awful lot of work to try and improve those things from a general palliative care. My plea from the report perspective is, please remove those acronyms and or explain them, because yeah, I read through most of it with a good understanding. However, then you just get confused about it. I don't need an easy read version, thank you very much. I just need something that explains what those acronyms mean. And I would be happier with that. So it's good to see the strategy. Again, you know, I also will really welcome, you know, how they're going to meet those 8 outcomes. You know, it's a long journey. It's always going to be a long journey of improvement on any service. Yeah, and timescales associated with that as well would be great. So thank you. More comments.
Dave, would you like to respond?
Yeah, no, thanks for your helpful comments, and kind of certainly take that back to the steering group for us as we move into the next stage of this work. So, you know, in terms of, you know, a lot of the kind of focus is around that sort of education, the awareness, the support, and making sure that everybody's, you know, the public and professionals understand kind of what support is around and how to access that support. So absolutely kind of critical. We hear that and the experience that people have had to take that back. And thanks, so, you know, Colin, in terms of your kind of comments and questions. So yeah, the delivery plan is where we kind of get the bit more of that detail, and that's where we'll know, hopefully once we've done that, that'll kind of give everybody the assurance that yeah, what we've said, strategy is, and you know, the how is this is no. This really turns it into firm action so that people know what that is, and be held to account to deliver on that one. I had followed up on the Dundee data, and it's one of the issues that we've got, which we need to obviously improve on, because it just doesn't exist. So it's around, or consistency doesn't exist, I should say. So there is information, but it's not consistent. So, you know, a whole part of this work is around building the data, and also then building the performance measures, performance management kind of aspect around it as well, so we can reflect back in terms of this is what we've actually achieved from this too. So I'll take these back to the group. Thanks.
Nicola, you want to come back in?
Just very briefly, yeah, I'm just noting the language as well, and the shift to care around dying versus end of life care. I'm not expecting an answer really to come from you, Dave. But what is this adding to the party? Really, my observation.
Dave.
Yeah, yeah. I mean, that's what's being used as part of the kind of narrative of the national strategy. So, you know, there'll be probably, if I was to bring in the sort of palliative care specialist, they would have a view on that. So I see Angie's got her hand up as well.
Angela.
Yeah, so the change in terminology around that was largely because when the Scottish one was being developed, strategy was being developed, there was a lot of discussion around what the different definitions mean, and there's always been a tension between what is palliative care, what is end of life care. One of the biggest challenges that are the feedback that a lot of services have received over probably 10-15 years now is that when you're talking about end of life care, people don't necessarily understand the relative is actually actively dying, so they have changed the narrative so that it is care around dying, so it's very specific.
Yeah, that makes sense.
Thanks for that, Andrew. Thanks.
So that's the chair of NHS Tayside has just left the meeting. So yeah, quite a few comments about this report, and we are asked to note and approve it. Are we happy to do that, given that the comments that members have made this morning will be reflected back, and that the delivery plan will flesh this all out in much more detail? Yep, thanks very much.
Thank you. So we've covered items 10 and 11, so that takes us on to item 12, Health and Care Staffing Scotland Act 2019 statutory annual report, and it's for a decision.
Okay, Catherine.
Thanks, Ken. I'll be very brief given the time and where we are in the agenda, and also given the fact that this is an annual statutory report and it differs significantly to the report that you saw last year, as is explained in the cover paper. The only thing I would say is just for members to be aware that the report, for the purposes of Dundee City Council's responsibilities and content, was approved by City Governance Committee on Monday night. Just for recommendation 2.2 refers to that. So just so people are aware, I'll leave it there, Ken, and just leave it for questions if anyone has any.
So are there any questions on this report? I don't see any hands. So are we happy to accept the recommendations from 2.1 to 2.4, particularly to approve the 2.3, particularly to approve the content of the draft annual report, which is in Appendix 1? Yeah. Thank you.
Item 13, Information Governance Annual Assurance Report. You have this for noting.
Yeah. Now, who's going to speak? Claire. Hi, Claire. How are you?
Hi. So this report is the first Information Governance Annual Assurance Report, and that it has been, sorry, I've lost it's reporting it's an action within the Governance Action Plan. So it sets out the information governance arrangements that are in place for Dundee Health and Social Care Partnership and the responsibilities for the Dundee City Council and NHS Tayside, and the improvement actions that we've identified as priorities. So I think I'll just focus on the improvement actions that we want to do. So our data protection training compliance, we want to improve that, especially for Dundee City Council. So our e-learning module is only at 39%. That is lower. However, it is a refreshed training module. So the previous training module, we had a much higher compliance rate. So we'll get information out to staff around the importance of completing those mandatory e-learning. And if I just go down to the improvement priorities, we're developing an information asset register for the IJB. We're doing that with support from NHS Tayside. We'll reinforce the importance of data protection impact assessments for all new kind of information holding processes. We're hopefully recruiting to records manager post for Dundee Health and Social Care Partnership. So that's going to add resilience and capacity within this area. And we'll be doing a refresh of data mapping across Health and Social Care Partnership processes. And also information governance is a very important part of digital working across our systems. So we'll be working with NHS Tayside and the council and nationally around doing that as well as we can to streamline our information systems for personal data.
Any questions on that? Colleen.
Thank you. Yeah, thank you for the report. Just a couple of little questions. So first of all, on page 339, around the, as you just mentioned there, the data protection training compliance. So the narrative here is that we tell people that they have to do it because there's not enough of them doing it. But my concern is that there was a significantly higher rate of completion in the old model. So shouldn't we be looking at what the new module is like, and if there's something there that is stopping staff completing this? Because I'm sure nobody wants staff's job to be more difficult, whether it's longer, whether it's, I don't know what it is, rather than just saying, well, you have to do it. Is this a new statutory mandatory module that we have to use, or is there something within it that's maybe not as good or accessible as the old one? Is my first question. Secondly, there's a mention of an increase in SARS, but it doesn't say what kind of increase. Is it something that we should be concerned about? Is it a dramatic increase? Is there specific areas that have had several these kind of things? And my last one is, now I'm going to have to try and find the pages because I've written down that on page 347, it mentions that our risk appetite is high. Apologies. But then I think on page 349, it's listed as cautious. Where are we? Yes, so 349 for the risk reference 9 IJB is listed as we have a cautious appetite, but on 347, can't find it now. Okay, ignore that if nobody else can find it. Just my other question, sorry. Thanks.
So the e-learning modules, I think that is just that the staff we haven't raised awareness of the new e-learning this is for the council's e-learning. And I think it's that we haven't alerted staff to there being the refreshed GDPR module. I think it's that. I don't think that there's anything intrinsically different about this e-learning or people are failing it. I think they've done it a couple of years ago and they've not got round to redoing it again because they haven't been aware. We have, when we log in to a certain part of our kind of HR system, you can see the policies you've got to read, but maybe for the e-learning it's not as mandatory. So we're hoping with the new posts and kind of additional capacity within this system that we'll be able to kind of raise staff awareness around that, and that will be part of the priorities to raise awareness. And so for the SARS, the subject access requests, so for NHS Tayside, they process all of the subject access requests they get around they're the data controller for. They can't break it down for their service areas, which are Dundee Health and Social Care Partnership, because obviously it'll probably come in and people say they want everything. So that could be across all 3 partnerships potentially. So they're not able to break it down for that. For the council, yes, we are getting an increase in subject access requests and they are becoming more complex, and people seem to be using AI to draft these requests and ask for metadata, etc. They are becoming more complex, and we do, again, with the recruitment to the records manager post, we're hoping there'll be additional capacity there and look at that. Again, people are using AI to make these requests, it seems now, that are more complex as well. So yeah, there's that. And for the risk appetite, I think that might be just an error on my part. I'm afraid my numbers aren't tallying with your page numbers at the moment. I'm on page, I'm like, oh, I don't think that's right.
Yeah, but me neither. I don't know. I mean, there was all sorts of numbers being quoted.
Sorry, I give the PDF number rather than the big number in the corner.
Yeah.
Sorry, that's maybe what it is. Sorry.
Right, okay. So, but
it's okay. It's okay.
Yeah, so I think that's probably just an error of mine, because that's the first time I've written the reports using the new risk, and so there is a bit of manual thing that I might have clicked on the wrong category.
Thank you so much for all those responses. Yeah. That's great. Thank you.
Next up is Jim McFarlane, please.
Yeah, thanks, Claire. It's kind of following on from Colin's point, and you probably answered it a little bit, Claire, but it is the issue around we've had with e-learning for some staff who, are not sitting at a desk, who don't have access to a workstation, and sometimes who are not working in a building, so they're out in the community. So it's just making sure that, to increase the numbers, that these people have to get dedicated time during their work to complete that and access to a facility to do that. And then that sometimes obviously needs cover for the duties that they're doing and stuff like that. So yeah, I'm just kind of highlighting that.
Yeah, no, exactly. And we get the breakdown of the people who have completed it. And yes, the people that are out and about, that sometimes it's them that haven't done it. We used to kind of have learning in OD when we had the lab, that they'd have dedicated time, wouldn't they, to do these mandatory modules. So again, I think it's about staff awareness, and that is a priority for us to get that done for not only for the GDPR, but for all the mandatory learning.
And last up is Bob.
Thanks very much, Claire. Very helpful. Do we have any information on data breaches, Claire?
Yes, we do. So the data breaches are reported. Sorry, this is on it's 8.7 of the report. So that's page 334 or 340. So the council, for our council data breaches, we've had near misses, but we've only had one data breach that was kind of reached that threshold that was reported, and it was around an email being sent to the wrong email address. So we know that that's significant underreporting. We know that these things do happen. They probably happen less often for us than they do, say, for example, children and families, because our client base is kind of more stable. But for the council, sorry, for the NHS, these are recorded on Datix, so there is a lot of information there about that. And if we'd have had kind of more time to kind of analyse it, we would have been able to get into Datix and look into all of these individually. So that's the kind of the NHS data breaches there in the table, and 8.7.
And if I may follow on from that, within the Care Reform Act Scotland legislation, there's proposals for a single health and care document record. How are we involved in this likely development as they take the legislation forward?
I think we'll probably Steve can answer.
Yeah, no, thanks, Bob. So, I mean, the issues for us will be around the partner bodies, because they're the kind of data controllers, etc. So we're kind of work. So we're still kind of waiting some more clarity on some of that just now in terms of what exactly we need to be doing. But we will work with the partner bodies around how that will be delivered. Because it's hugely important, and I think it'll be a really kind of significant step forward. I mean, we've been talking about this for years about, you know, that wouldn't it be good if we had that single record, and we've never been managed to crack it. So that kind of national impetus around it is really helpful.
Thank you.
Okay, I see no further hands, so we'll move to the recommendations, which are for noting, and also at 2.3 that we acknowledge the respective responsibilities of Dundee City Council and NHS Tayside as partner organisations. I don't anticipate opposition to this, and I don't see any. So next item, thanks.
Okay, that takes us on to item 14, Annual Complaints and Feedback Report 25-26, and it's for noting.
Claire, back to you.
So one of the main things to highlight for this is that we've had quite a significant increase in complaints for this year. So we're up to 266 complaints received. So that is a significant increase. The highest proportion of complaints continues to be around our mental health services. And we've just outlined the governance around complaint handling, so the weekly reports that we have with the patient experience team with NHS Tayside and with the managers for those services. That happens weekly. And what else would I wish to highlight is, yes, in terms of our complaints close within timescales in section 8. So yes, we can see that we were at 59%, 69% for social work and health for stage 1, 60%. It drops down to 33% for stage 2 for health. But these are complex complaints. So we do work with the teams that are handling the complaints, but I think probably that the capacity within the teams to handle these complaints, when the complaints are also about waiting lists, etc., means that the complaints aren't being completed within the timescales, but that it is an aim for that to happen. We've also got a breakdown in section 9.2 around the complaints for the different service areas. That's information there for you. And also care opinions. So just to say that we're getting very positive stories that we receive on care opinions. So although there's the bad news about complaints, is that actually, you know, we do get really good feedback from care opinion as well, and that it continues, it's a priority within our service area to manage complaint performance. And that's any questions.
Yeah, are there any questions? I guess it's a concern that they're up, I think it's about 50% actually on last year, isn't it?
Yeah, it was quieter for a couple of years. But yes, it has come back up again.
Although 24-25 was the lowest in the 5-year period, wasn't it? So
yeah,
hopefully this is just a blip. David Cheap, please.
It's a quick one, Chair. I think Just hearing about the numbers, increase in numbers and things, but realistically, I think it's less about the volume of complaints and about how they're handled and what we learn from all of that. And I think if we're moving forward and that we make sure that, you know, there are adequate responses and agreement as to how these things are handled, that they actually that is held to, and we hopefully would see a better quality of service if that's looked into rather than looking too much at the number of volume of complaints. Just a passing comment.
Yeah, that's a good point, David. Anyone else? I don't see any other hands, and this is for noting. So next item, please.
That takes us on item 15, Category 1 Responder Annual Report 25-26. It's for noting.
And Angie, you're going to speak to this, I believe.
Yeah, thanks, Chair. So this is our annual statutory update paper outlining how we're meeting our statutory responsibilities, preparing for and responding to resilience-related activities. The work continues to exercise and plan, specifically at this point around IT outages and the potential for a national power outage. Our most common responses over the last year have related to IT outages and storms, with our business continuity plans working very well where they have been implemented. There has been no requirement for rest centres in the last 12 months, with our housing colleagues responding very promptly, so we've been stood down quite quickly. The care home evacuation guidance has been updated, which incorporated the learning from the South Grange evacuation, and that's the key areas I would like to highlight. Happy to take questions.
I think that's a fairly straightforward report. I noticed that Dave had a storm named after him in April. Minimal impact, which is good. No hands up, no. So yeah, it's for noting, and also to instruct the Chief Officer to bring forward a further annual report next year. Thank you.
Item 16, Children's Services Planning Partnership Plan 26-29. It's for a decision.
And I have the pleasure of introducing Alison Penman to the meeting. Good morning. Good afternoon, actually, now.
It is afternoon. Thank you very much. I suppose just to highlight, we have a statutory duty under Part 3 of the Children and Young People Scotland Act 2014 to prepare a children's services plan. So since 2017, we have delivered this through a regional model linked to the Tayside Regional Improvement Collaborative. And that has supported collaborative developments focusing on early years, digital learning, emotional health and wellbeing, care experience and child protection. However, partners have agreed to revert to a localised model for the 2026 to 2029 plan, and that's in response to the recognition of differing local governance and structure arrangements. Although it should be noted that there will be continuing regional collaboration where this adds value. So, for example, the health priorities are ones that are shared across Perth and Kinross and Angus through NHS Tayside. So you'll see from the report the plan has been developed jointly between Dumfries City Council, Dumfries Dundee City Council, NHS Tayside, Police Scotland, Dundee DH&SCP, Dundee Voluntary Action and other third sector organisations. It is based on an analysis of a range of data that we've used quite intelligently. It's based on the strategic needs analysis and feedback from children and families, and it is informed by and aligned to relevant local plans and priorities. So it sets out a vision for Dundee that all children, young people and parents or carers receive the right support at the right time with kindness and respect. And we're suggesting 5 priority areas to realise that vision. We've got place-based whole family support, physical, mental and emotional health, presence, progress and participation in learning. So that's in terms of our attainment and achievement. We've got children and young people who are at risk of harm, and we've got our promise for those who are care experienced. The plan interweaves the principles and requirements of GIRFEC, UNCRC throughout, and it also incorporates how we would equip our workforce to deliver it. The interface with adult health and social care strategic plans is included in the paper, and it highlights that the delivery of key priorities requires active contribution from Dundee DH&SCP, services that are commissioned or overseen by IJB, and it notes the strong interface between this plan and the Plan for Excellence in Health and Social Care in Dundee. The plan will be overseen by the Child Poverty and Inequality Strategic Leadership Group, with annual reports in accordance with statutory as well as governance requirements. Also to note that the plan was agreed by Dundee City Council on the evening of the 22nd of June. So I think that sums it up unless there are any questions.
Just give it, yeah, Colleen.
Just a quick comment. Yeah, thanks for the report. Really an interesting read. There's some really stark kind of read in there and the challenges for young people, but nice to see the signs of hope and change for the better as well. Around the thematic priorities, which I think are great, are we going to see some kind of metrics around them to measure the success, like back to the IJB here, as it progresses? Because is it a 3-year plan, 2-year plan?
It's a three-year plan.
Yeah.
Thank you so much for the question. Yes, it's a 3-year plan. We have to provide an annual progress report anyway, so it could be that that's what would come back to the IJB for reporting. When we've looked at our outcome measures, we've tried to get a good balance between quantitative measures and answering the so what question that we always ask ourselves in terms of what real and tangible difference are we making? How does it feel different, and how is it experienced differently by our communities and by our families? So you'll see that within the body of the plan. We've tried to be a little bit more creative in terms of how will we know if it's making a difference or not. But that will be captured through an annual progress report.
Fantastic. That's great. Thank you very much.
Yeah, thank you, Alison. I don't see any other hands, and this is for noting as well as a remit to the Chief Officer to review the risk register with reference to the information contained within this report. Next item, please. Is this near the end?
Yeah, so item 17 is the meeting attendances that you've got for information. Item 19 is a list of the development sessions that have been arranged, and can I just ask you to note that the September topic is now the review of the risk appetite, and then the last item is the date of the next meeting, which is the 19th of August.
Okay, thanks very much everyone for your attendance at what's been quite a long meeting this morning, but I'll let Dorothy in before I conclude.
Could I just say something about frequency of meetings? I find it quite difficult to have, approaching 400 pages of reports. And I'd be up for additional meetings. I don't know if there are any rules around this. I don't know what other board members feel about it, but this is going to be a difficult year, clearly, and reports seem to be increasingly complex, or the issues appear to be increasingly complex, and I just wonder if we could, slot in 1 or 2 additional meetings to kind of spread the load a wee bit better. I don't know what other people feel about this.
I think we're about to find out what Bob thinks. Bob, you're next. You're on mute, Bob.
I agree with what Dorothy's saying in principle, but I would probably focus much more on financial monitoring of our budgets. I think that's a key issue for me looking forward, and I think Dorothy might concur with some of that as well, because we sometimes get overwhelmed by all the other items we need to look at. And I certainly think some of the areas around that performance as well, particularly to absenteeism, which has been well talked about as well. But I do think that we have to create some time for ourselves to look at these and have up-to-date information. At the moment, we're looking retrospectively back at information, so we don't know where we are in the here and now financially. And we know that we're going to be faced with having to make difficult decisions coming ahead. And I should also say, in the context of the new voting rights coming in September, which I had hoped we'd get some insight into that today, but I believe it's not going to come until the August meeting. So that won't give much time for the carers and service user reps and third sector reps to be brought up to speed on those expectations, which are slightly different from the position they currently hold. So there's something around that as well, and that will have an impact on our decision making too. So I think Dorothy has a case here, and I think we should look at that with the Chief Officer.
I'm on the fence on this one at the moment, but David?
Yeah, I'm not averse to any of those ideas, but I totally agree with Bob. You know, that we get lots and lots of reports, and there's a lot to them, but a lot of things we're reporting on aren't going to be around if we don't have this financial sustainability we keep talking about. So that's got to be the highest part of our agenda in all of these meetings we're having. But until we can get ourselves onto sustainable footing, that's the priority. I think, Dorothy, as far as the papers, I totally agree with the length of them, but we've done it in other places where we get, and we should be getting, a candid 4 or 5 page summary report for each paper we've got. The actual, for example, annual reports or anything else can be simply put in with a link in there to actually allow people to view them. I know you like papers, Dorothy, but so I can't argue on that front with you. But you know, there should be sufficient information in the summary part of the report that introduces the actual full report to give us all the information we need. And then if you have the time and inclination, you can go in and look in greater detail at the report. But simply putting in pages and pages into the report, into the body we're getting, that's where we're getting our 400 odd pages from. So then there's a simpler means to do that, I think. And but as Bob says, we've got to get the focus on the key priority on this year. And that's the questions we dealt with today. Financial sustainability, impacts of absence, things like that. These are the key ones for long-term sustainability.
Nicola?
Just very briefly, going back to Bob's comment about the voting rights, and just to assure everyone that Martin, Chris and I are very well cited on the developments with regards to voting rights. We've all been involved in joint and separate national conversations, and we will be meeting with senior management team and whoever's relevant, and will be well cited on the paper before it comes in August, I am assured. So yeah, we'll welcome those developments. Thank you.
Yeah, thanks for that, Nicola. That's actually quite reassuring to hear that. Dave, Berry.
Yeah, no, thanks, guys. I just want to come back in around this conversation. So, I suppose for me, if there's the issue around the frequency. So, the moment we have six IJB meetings plus 1 budget meeting, plus in between we've got 4 PAC meetings a year. So that's a lot of kind of meetings that we have. Alternatively, we also have the development sessions as well. So, I need to kind of consider from my team's capacity around being able to support any additional kind of asks that come in, and we would kind of, I would take it back with Roger around. Look, we need to kind of change the standing orders, which set out how many meetings that we have a year. Excuse me, around that. I think given the conversation, and I'm happy to look at the format of reports as well to kind of see if these need to kind of change and be a bit kind of more contemporary in style. If people are looking for a shorter kind of sort of summary at the front of that in terms of the to give that message of what the report is around. Also happy to look at the range of reports that we put in as well. Now some of these will be statutory reports. So today, we'll look at today's agenda. There's a lot of reports actually we have to put up, annual reports, so there's statutory reasons why we need to do that. But there are others that are either ones that we've kind of over the years undertaken either custom and practice because we think it's been a good idea to do that, or there have been specific asks at a point in time from IJB members to kind of report back on particular reports. So kind of happy to look at our work plan over the kind of the common period, say, well, actually there are things that we actually don't need to take or can provide information on a different way that doesn't take up the papers or the paperwork within the meeting. So yeah, obviously there's echelons coming in as well, but I'm happy to take away those reflections back to the team, given the feedback we've received today.
Yeah, I'm actually no longer on the fence. I wouldn't be in favour of an increase in the number of meetings, given what you've just said, and about the statutory reports that need to come every year. Because thinking back to the last couple of meetings, I think it's been a much lighter agenda. This has just been a bit of a heavier agenda. And given that we already have 6 meetings plus the budget plus the development meetings, I do agree that I think an increase in the number of formal meetings would be excessive. And I'm going to finish with Siobhan.
Yeah, thank you, Chair. Yeah, I have to agree with that. I'm not necessarily convinced that more meetings are the answer. It's the old kind of, the bin analogy that we might just end up having more meetings with more information that we need to discuss. I think that the way coming round this is actually looking at ways we can streamline that discussion. David, picking up on your kind of notion that some of your staff, you need to check the capacity. No offence, but I think we're all at capacity, actually. And I think that maybe the focus should be that we can try and streamline that information and try and get the most out of it in the shortest space of time, rather than adding more meetings into the mix. That's from a personal perspective, of course, because I kind of manage another job here, so I kind of have to constantly take time out to attend these meetings, which becomes increasingly more difficult. But I am aware that most of us are attending meeting after meeting after meeting. So I think we need to come at it from another angle in terms of just being quite not ruthless, well, maybe ruthless in terms of what exactly we need to discuss here. My concern is, as I said, that we'll move beyond statutory because we've got meetings to fill and just move more items into the agenda and give us all more work as well. Not averse to that necessarily, but I do think we need to kind of manage all our workloads here and get the best out of the papers that we can.
It's just occurred to me that maybe we should. I mean, this is any other competent business that we're discussing now, but we never have that in the agenda. Perhaps we should put AOCB on the agenda with a 10 to 15-minute absolute time limit for issues like this that come up that that are pertinent to the work that we do. So I don't know what others think of that, but how about AOCB also added to the agenda, but with a time limit, so that we don't end up sitting here till like 3 o'clock.
Well, it could be, Ken, that you might think about, say, meeting reflections and stuff like that. That's another alternative approach to it.
Yeah. I think David Cheap flashed up there, but put his hand down again.
Just a thumbs up for you, Ken. That was all.
Oh, okay, right. It was a thumbs up. Okay. So now I think we've got to the end of the meeting. And I put the papers away, so I don't even know what it is. Was it just attendances, or was I just saying cheerio to everyone? I can't remember now. I was thanking you for what's been a long meeting on a nice day, and I hope that whoever can got out into the sunshine for a bit and remember to use your SP50. Thank you.
Thanks, everyone. Bye.
Bye.
Bye, everyone. Thanks now. Bye-bye.